Dr. Laya. I'm a senior resident in the Department of Surgery, and I'm going to talk about
Welcome back to post-lunch session. We have started this hall for case report presentations and original article presentation for selecting the prize. Okay. Okay. Before that we have a lecture by our young faculty, Dr. Laya, Dr. Lakshmi. Post that we will be starting case reports and original article presentation. Now we know Dr. Laya to start her presentation. Dr. Laya is SR in JIPMER. She is presenting on pancreatic adenocarcinoma.
Good afternoon, everyone. I'm Laya. I'm a senior resident in the Department of Surgery here at JIPMER. And today we'll have a discussion on borderline resectable pancreatic cancer. You'll have to help me out. I'm not going to make it a lecture. So we'll make it interactive. So today's agenda, I'd like to introduce the topic to you all, define what is borderline resectable, what imaging is used to diagnose this malignancy, what is the treatment, which is like neoadjuvant and surgical management. So the term borderline resectable was introduced by the MD Anderson Cancer Group in the year 2006. They found that margin negative resections offered an 18 to 24% 5-year survival rate for patients with pancreatic cancer, which makes margin negativity quite an important factor in their prognosis. So, why did we divide it into resectable, unresectable, and borderline resectable? 70% of pancreatic cancers were unresectable at presentation, 20% were resectable, and around 5 to 10% of tumors didn't fit into either category. So, why do we need a separate entity? If you undertreat these patients and treat them like unresectable, they're denying those patients a chance at cure, right? So on the other hand, if you treat them like resectable, there will be a higher margin positivity rate because borderline resectable is based on relation of the tumor with the vascular anatomy. So higher margin positivity rates could be there. So they decided we need a separate entity so that we can try something else like neoadjuvant therapy, maybe downstage them into a clearly resectable tumor. Now, the whole of this lecture, this is a very controversial topic. There are multiple guidelines, multiple definitions of the topic of borderline resectable. There's a lot of differences in what people prefer to give as treatment. So I'll be focusing on NCCN, which would be more helpful for the postgraduates. So before moving on to the classification and the guidelines, I'd like to introduce the terms to you all. Okay. So the first term is abutment. Can someone tell me what is abutment? Nobody knows what is abutment? It is touching. It's in contact. Okay. So abutment is when the tumor is in contact with a vessel, could be an artery or a vein, of less than 180 degree. For the juniors here, this 180 degree is in relation to the circumference of the vessel. Okay. So 360 degrees would be there. This is less than 180. So it is abutment. Now what is encasement? More than 180 degree contact. That is what is given in the picture. Then we have something called contour abnormality. Because of the tumor, if the vessel, be it artery or vein, if it loses its circular shape and becomes like a teardrop or an oval or something, that would be a change in its contour or outline. So that would be contour abnormality. I'll show you the CT images later. Now, NCCN decided to divide borderline resectable based on the relationship to its arteries and veins separately. So in arterial, you can see a CT here. This is the tumor which is outlined in red, and you can see that it is in contact with the superior mesenteric artery. The contact area is less than 180 degrees. So the definition says that arterial borderline resectability would be solid tumor contact with superior mesenteric artery less than 180 degrees, or a tumor contact with common hepatic artery without extending to the celiac or its common hepatic bifurcation, and a tumor contact with a variant arterial anatomy, like a replaced right hepatic artery or so. This is only for head and uncinate process tumors. Rest of it I'll tell you in the next slide. Now moving on to venous. This is a CT showing the superior mesenteric vein, which is supposed to be round and it's not round, which is called contour abnormality. Okay, so this is solid tumor contact with the SMV or portal vein more than 180 degree, or a tumor contact less than 180 degree with these two veins with a contour irregularity, or its solid tumor contact with the IVC would be borderline resectable in venous. What we have to know is that this tumor contact with contour irregularity is only if the proximal and distal part of the vein is patent and uninvolved, so that we can have options of reconstruction. That is the addendum to this. Now, I told you earlier, for body and tail, that separately put something else because the relationship to the vessels is different. In the CT, you can see your CA, that would be celiac artery. So in body or tail, borderline resectable would be less than or equal to 180 degree contact with the celiac axis. Now, according to the International Association of Pancreatology, they've divided this borderline resectable into 3 types. Does anyone here know already what are the 3 types? ABC, yes, they both correct. So we have type A, which is anatomical borderline resectable, which is what I described earlier. Then there's type B, which is, yeah, it is biological. So what entails biological? Biology is the tumor's biology. Okay. So that means that you're suspecting a metastasis in the tumor, but it's not proven metastasis, or it could be a CA19-9 value of more than 500, which suggests that the tumor could have spread elsewhere. So that would be borderline type B. Now what is C? Yes, conditional. Whose condition? Tumor, vein, patient's condition. So that would be performance status of more than or equal to 2 would be a borderline patient. So a borderline type C. Okay. Now in 2016, this International Association of Pancreatology in Sendai in Japan, they decided to further classify it into PV and A, which means PV is portomesenteric axis involvement, A is arterial, just for completion's sake. Now moving on to diagnosis. What imaging modality do we use for diagnosing pancreatic cancer in general? CT. Okay. What kind of CT? Which is a contrast or a non-contrast? Meaning it needs to have got. Okay. So this is, we need a multi-detector CT with a pancreatic protocol. I'll tell you the protocol later. Do we use MRI for pancreatic cancer diagnosis? Yeah. If there is a doubt, you're very good. So we do use MRI if our CT is not giving us a clear-cut diagnosis of a tumor, and small tumors sometimes that cannot be picked up by CT. When do we use PET CT? Do we use it? In neoadjuvant therapy, or in some centers they routinely do it. So response assessment after your neoadjuvant would be better with the PET CT. But this is again like it's not in the standard recommendation, it's suggested. Next is endoscopic ultrasound. This investigation has around 70%, 70 to 75% sensitivity to detect small pancreatic tumors. Where do we commonly use endoscopic ultrasound in pancreatic malignancies? For biopsy, okay, so is biopsy mandatory in pancreatic cancer? No. Okay, so biopsy is recommended for what? For initiating chemotherapy. So now there is also staging laparoscopy that is recommended. The role of staging laparoscopy is when you have high risk features in your imaging or patient, which we'll talk about in the next slide. It is recommended in the NCCN guidelines. Now, peritoneal cytology, we all know if your peritoneal washings are positive, that makes it an M1 and undetectable or metastatic disease. So now what are the high risk features that would make you want to get a staging laparoscopy? Firstly, indeterminate imaging. You have a strong suspicion of malignancy, but you're not really sure. You're strongly suspecting that surrounding structures are involved, but you're not sure. Next would be a borderline resectable disease per se is defined as a high risk feature as per NCCN, which means that ideally for our borderline resectable tumors, we need to get a staging laparoscopy. Next would be a markedly elevated CA99. And the last is a large primary or a large lymph nodes. So now the CT protocol I was talking about, again, NCCN 2024 guidelines. The type of CT is a helical CT, 64 slice minimum. The slice thickness that is recommended is less than 3 millimeter, submillimetric if feasible. And they say that we are supposed to use an oral contrast. What oral contrast do we use? Water. Why do we use water? Why? Yeah, it will distend your stomach and duodenum so that your anatomy to your surrounding vessels are clearer. Plus, it doesn't interfere with your IV contrast. Your IV contrast should be an iodinated contrast at high concentration, given at a rate of 3 to 5 ml per second. And dual phase is recommended with a pancreatic parenchymal phase at 40 to 50 seconds and a portal phase of 65 to 70 seconds. So this is a CT scan. Can someone tell me what phase it is? This is a parenchymal phase. You can see the tumor in yellow and the white would be the pancreatic parenchyma and the dashed line is the region between the tumor. Between the two. Now, this is a portal venous phase. You can see that it's not very clearly visible here. So now, in some cases, we need to get a delayed phase CT, especially in isoattenuating tumors where you're not able to see a tumor in your other phases. If you do a delayed scan at around 4 to 5 minutes, some tumors will get in E, that is a delayed phase, you can see that your tumor is more prominent. Okay, so that was supposed to be a question. So this is what? That is the MPD, which is clearly dilated. This, that is CBD, and this, that's the tumor. So where is the pancreas? The pancreas is atrophied distal to it. Okay, so this would make it a what sign? This is a double duck sign. Okay. So now, can someone tell me what this sign is called? This is a teardrop sign. Like I mentioned earlier, your SMV is altered into a teardrop shape from a round shape. Who can tell me what is there in the CT? Liver, on the liver. Okay, this, do you see any lesion? Okay, there's no lesion on this CT. Okay, same patient, a diffusion weighted MRI was done and 2 metastases are seen. This is why we need MRI earlier, like we said, when there's a doubt of metastasis, we do a MRI scan. This is how it helps us. So now moving on to treatment, again, controversial, but again, the current guidelines recommend neoadjuvant therapy. We'll see why. This is the NCCN currently. For borderline resectable, they recommend a biopsy for giving neoadjuvant. Then consider staging laparoscopy because it is a high risk feature. A baseline CA19-9, which is important, and you can consider a PET CT. Some people do that. So now, is CA19-9 reliable? Is it always elevated? Well, can it not be elevated? When is it elevated? Other than malignancy. Cholangitis, yes. Any obstruction to the biliary tree, then Basically, any inflammation or obstruction can cause increase in CA19-9. When can it not be elevated but the patient has pancreatic cancer? Pancreatic ductal adenocarcinoma. Non-secretors because of the fucosyl transferase gene, which makes the Syli-Lewis antigen, which is, if it is negative, your CA19-9 would not be elevated. In those patients, there are some other tumor markers which you can use. One is CEA, one is CA125, and one is DUPAN2, which is Duke's pancreatic monoclonal antigen 2. Interestingly, if you see this in the ward, your CEA is elevated in 30 to 60% of pancreatic cancers. So if you're seeing a patient and your CA19-9 is not elevated, then you should get a CEA for the patient because you can use it for later for prognostication as well and response. So now what does the evidence say? There are multiple trials. There's scores of trials regarding neoadjuvant therapy in pancreatic cancer. I'm not going to elaborate on each of them. Jang et al., Priopanc and SPAC5F. Some of them used RT also, neoadjuvant. Bottom line, evidence says that in borderline resectable, neoadjuvant plays a role in increasing overall survival in the patients. But we need to do RT at our discretion. Radiotherapy does not have strong evidence. We'll come to that. So the neoadjuvant regimens, what do we use for pancreatic cancer? Modified FOLFIRINOX and anything else? Yeah. So modified FOLFIRINOX with concurrent chemo RT. Left. Sir, gemcitabine plus albumin-bound paclitaxel with or without chemo RT. And how do you decide how to operate? Basically, you have to rule out metastasis. Post neoadjuvant, you have to do repeat imaging. It's recommended to be within 4 weeks of surgery. You have to see performance status. You cannot just operate any patient at your whim and fancy. Progression of disease on CT, CA19-9 levels, whether it has fallen, whether it's stable. If it is increased compared to baseline, it is recommended to proceed with caution with surgery. So again, radiotherapy, the newer modalities of radiotherapy like intensity modulated RT, stereotactic body radiotherapy, and volumetric modulated arc therapy. Because of the advent of these, we have been able to give RT without damaging the surrounding structures. So that can be tried. But again, Alliance trial A021501, they took 126 patients and they gave an neoadjuvant chemo radiation on one arm, which is FOLFIRINOX and RT. On the other arm, they gave just neoadjuvant therapy. They found that overall survival was reduced at 18 months with radiotherapy. And increase in morbidity was noted. So RT is not currently strongly recommended. Moving on to the surgical aspect, I know we all know if it is a head or uncinate, we do a Whipple's pancreaticoduodenectomy. Distal pancreas, we do distal pancreatectomy with or without splenectomy. But what is interesting is the artery first approach, which evolved because people decided that it's better to decide intra-op whether the tumor has involved the artery or not before committing to a irreversible step like transecting the pancreatic parenchyma or transecting the bile duct. So before that, we need to evaluate the superior mesenteric artery. That is called artery first approach. It's an intraoperative thing. The other term we'll use is mesopancreas. Mesopancreas is the structure that connects the head of pancreas to the SMA and the right celiac ganglion. This area, which goes retropancreatic into the retropancreatic region, has all the lymph nodes and nerve supply of the pancreas, which has to be removed for adequate oncological clearance. So this is just a picture showing the different approaches. This is superior approach, anterior approach, left posterior, mesenteric, right or medial uncinate approach, a posterior approach. The details of this, based on where the tumor is located, you use these approaches to access your artery. I'm not going into details for due to lack of time, but these are the approaches. It's just probably not in the scope of this lecture. So now what is important is something called the arterial divestment and the triangle operation. The triangle that I'm referring to here is the triangle that is made between, like you can, this is the SMA. This is where the portal vein used to be. It is reconstructed, and common hepatic. So this triangle contains all that tissue which needs to be removed for an adequate resection. That is just what is called triangle operation. There are three levels of surgery. Level 1 is when you do not excise the lymph nodes. You just resect the tumor. Level 2, you do central vessel ligation and you go here. Level 3, this PL is plexus. Okay, so it has the nerve plexuses in the pancreatic head 1 and 2 and everything. So you go peri-adventitial around the SMA, just around the adventitia, without injuring the vessel. You take out all the tissue there. That is level 3. And the prerequisite for this level 3 is that the arterial adventitia should be free from tumor. Thank you.
Very good presentation. Any doubts?
Thank you for the presentation. I actually had two doubts. One regarding the pancreatic protocol, like what does it add to the prevailing CCT that is there? And the other question is, like, since the borderline resectable is high risk in itself, we proceed with DLAP then neoadjuvant. So during surgery again, do we do DLAP then only proceed, or it's directly surgery?
Ideally, all surgeries should have a diagnostic laparoscopy in the beginning. But why you're asking that question is because we don't do it regularly.
Yeah.
We are considering the laparotomy that we do as a staging laparotomy. So we do the laparotomy, we look for metastasis with our own eyes, which is equivalent to a staging laparoscopy. That is why you're asking that, right?
This is before neoadjuvant, or
after. You operate
Okay.
after.
Okay.
So that is also staging. Despite change in your response assessment CT, the patient still can have metastasis. It should still be a staging laparoscopy. As to your first question, you were asking about pancreatic protocol. Yeah, like I said, this pancreatic protocol has thin cuts. So tiny lesions which can be missed, or there are changes in attenuation which could not be made out. So that is the reason why we take all those phases, because ductal adenocarcinomas are better seen in different phases for that.
Thank you.
That was a really nice presentation.
Thank you.
I just wanted to ask, you were showing the indication for MRI and you showed liver mets, like MRI for doubts regarding mets, or whether like it's a pancreatic head mass, chronic.
Either.
When do you do?
It is not really in the recommendations. So suppose there is a patient who I am thinking there is metastasis. Patient CA is 780. So on CT, I don't see metastasis on the liver. Then I'd like to do an MRI just to rule it out before branding the patient as non-metastatic. So similarly, if you have a small tumor which is not seen on your CT, MRI would pick it up better.
In these cases, would you rather go for PET CT?
PET CT is can also be done, but MRI gives better definition of the tissue. No, PET CT, I'm not really sure about what to do in that sense, because PET CT is more for just ruling out metastasis. MRI is for pointing out where the lesion is and like describing it more.
You're saying if it's a very small lesion, even PET CT may not
pick it up.
Any other questions? Thank you, Dr. Laya. I'd like to invite Dr. Lakshmi Satish to talk on the topic of choledochal cyst.
Good afternoon, everyone, respected sirs and everyone who's gathered here. We'll have a very short talk on choledochal cyst. First of all, I would like to ask, why do you think this topic needs to be discussed? Anybody? Anyone? Yeah, okay. So it's okay, fine. Yeah. So we will start with a case scenario. These are actual cases from our own hospital, the Department of Surgery S3. So a 39-year-old lady, she came with complaints of upper abdominal pain, non-specific for 3 months, and obstetric jaundice for 1 month with fever for 1 week. She was deeply icteric and with no palpable abdominal mass or any other findings on examination. As you can see, she has conjugated bilirubinemia, ALP is high, counts are slightly high, tumor markers are also slightly elevated. So USD showed bilobar IHPRD, dilated CBD and mild free fluid. How would you like to proceed with this? Anyone? CCT, yeah, okay. So because we had a fair idea about the condition, so we did an MRCP, okay? Anybody, what are we seeing in the MRCP? Okay, just keep, take a look and we'll come back to this. This is another case, a 33-year-old woman with feature suggestive of obstetric jaundice for 5 years and mass per abdomen and loss of appetite for 3 months. On examination, she had a palpable gallbladder, tumor markers were normal. UST showed a dilated CBD, distal CBD tapering, could not visualize properly, a porcelain gallbladder with small stones in GB with bilobar IHPRD. Again, even in this case, as you can see, this is what we have gotten in the MRCP. Okay. We'll come back to this. So, in this talk, we'll briefly talk about the types of colorectal cyst, why we need to know more about colorectal cyst, and what is the pathogenesis or the theories proposed for colorectal cyst and treatment in short. So, it was introduced by Vater et al. In 1723. So, choledochal cyst would strictly mean, choledocus means bile duct. So, it would strictly mean an extrahepatic biliary duct dilatation. So, a more semantic way of putting it, it would be a bile duct cyst or a biliary cyst. It's also known as a congenital biliary dilatation. It is defined as congenital dilatation of extrahepatic and or intrahepatic bile duct. So, if you ask me, how do you define a choledochal cyst? Beyond what diameter should we call it a cystic dilatation? So there is no specific or defined criteria to define the cystic dilatation of bile duct. So why do we need to discuss colorectal cyst? Colorectal cyst, we don't see many cases of colorectal cyst in our wards. Why is that? How many percentage of colorectal cysts are present in adults? It's only less than 20%. So 80% of them present in children. Right, so they present as neonatal jaundice, failure to thrive, or even neonatal failure to thrive. Yeah, so it is a pre-malignant condition. It is extremely rare, and the presentation, as you could see, it is just obstructive jaundice, and it's like extremely non-specific. Because it is pre-malignant and it's non-specific presentation, it's a diagnostic dilemma. We need to have high clinical suspicion to detect it and treat it. And once we treat it, that is, once we diagnose it early and excise it on time, it's been shown that there is an 89% event-free rate and an overall 5-year survival rate above 90%. So how does it develop? Any ideas on how a colorectal cyst develops? Anything? Okay, so since 1700s, there has been like multiple theories proposed for the development of colorectal cyst. Okay, so briefly we can classify it as congenital anomalies. So any anomalies in the biliary junction, biliary ducts, which might cause a proximal biliary dilatation, right? Or a wall weakness theory. Weakness of the biliary duct and its walls can cause ectasia, dilatation, and the resultant changes. Or an obstruction theory, which means anything in the distal bile duct which can obstruct the distal bile duct pancreatic duct junction and cause a proximal CBD dilatation. Or dual theories. Dual theories means there is an element of wall weakness as well as obstruction. We'll talk more about it. So there were so many lines of thought, right? So before Babbitt theory is the most commonly used explanation for colorectal cyst. Before that, we used to wonder, like, is it a part of a complex anomaly of the pancreatic biliary system, Or is bile duct dilatation and anomalous junction happening simultaneously during embryogenesis? Or is it a secondary change due to any obstruction in the distal bile duct? These are all certain like lines of thought. There has not been any particular proven cause for choledochal cyst. That's what I'm trying to. So Babbitt in 1986, actually many authors have cited the coexistence of an abnormal biliopancreatic ductal union, okay, ABPDU. So many authors have cited that ABPDU coexists with choledochal cyst. But Babbitt was one of the first 5 authors to actually establish the causative or explain the causative relationship between a choledochal cyst and an anomalous pancreaticobiliary junction. What he proposed is that, so what do you understand by ABPDU? Anybody? Anything that you know about it? Yeah, like I said, abnormal pancreaticobiliary ductal union, but what more? Anything more you know about it? So how does, what is a normal thing? What is a normal pancreaticobiliary union? Junior residents? No, okay. So normally a pancreatic duct and the bile duct joins in the duodenum, right? Always? No. It can join in the duct, in the duodenal wall or very close to the duodenal wall. So anything less than 1 centimeter of the duodenal wall can be considered normal. Right? We call it a long common channel when it forms a common channel outside the duodenal wall and the length is more than 12 mm. Okay? Actually, there is multiple documents which show otherwise, like 12 mm, 10 mm, and all that. So, fairly to say more than 1 centimeter, you can call it a long common channel. Okay. So, what happens when there is a long common channel? Okay, there will be reflux of pancreatic juice into the bile duct. Why? Why does it not happen usually? Yeah, so sphincter is no longer able to control the secretions, right? So there is a bidirectional flow. So there is a reflux of pancreatic juice in the bile duct, and then yeah, in medical terms, inflammation, ectasia, dysplasia, etc. Right? So and mostly these ABPDUs are associated with some obstructing lesions in the distal bile duct that can also result in the proximal dilatation, right? So we all know the classifications of choledochal cyst. This is one of the basic things that we learn. So Alonso had classified choledochal cyst in 1959 itself, 3 types only. So this classification was modified by Todani to include these 5 types broadly. Type 1 has been divided into 1A, 1B, and 1C. Can anybody see any difference between 1A and 1C? Both are cystic. Yeah, right, that's right. So type 1C, there is also an involvement of the CHD part, okay? It reaches the confluence almost. Type 2 will be like a focal dilatation of the extrahepatic biliary duct. Type 1B. Type 2 is a diverticulum of the CBD duct. Like it's more like a GB coming out of the CBD, right? Type 3 is dilatation of the bile duct, which is inside the duodenum, the intraduodenal part. It's also called as choledococele, right? T4 is divided into 4A and 4B. As you can see, 4A has dilatation of both intrahepatic and extrahepatic structures. It's more like multiple cystic structures. If you can, they were trying to show that difference here, you know. Type 4B and 1A, if you compare, multiple cystic dilatations. Type 5, Caroline's disease, it is intrahepatic cystic dilatations. And this is what we said. Anybody knows the types of ABPDU? Like different variants. Okay, let's not. So as I said, type 1A is entire extrahepatic bile duct, type 1B is focal, and type 1C is the common hepatic duct portion actually. Type 2 is a diverticulum. The types that are associated with this pancreatic biliary malunion is only type 1 and 4, right? So only these choledochal cyst and its pathogenesis is explained by the Babbitt theory. So there is around 5 to 20% of choledochal cysts which are not explained by that theory. So that's why I say that there are multiple theories like congenital wall weakness and all that, but nothing has been like solid yet. So there's no proper reason for it. Is there anything called type 6 choledochal cyst? Anyone? Yeah, it is an isolated cystic duct dilatation, that is type 6. And what is this? What is this? Sorry. What is this? This structure. Yeah, it is a CBD. And this? Cystic duct. So it is, if it is an isolated cystic duct dilatation, it is type 6, right? And if it is combined with the extrahepatic biliary tree, then it becomes, they have proposed, okay, they've proposed type 1D, type 1D, or sometimes they call it 6B and all that, but these are not officially part of any classifications, right? So how do they present? They, as I said, 80% present in childhood. They present with failure to thrive, abdominal mass, jaundice, ecolic stools, failure, abdominal pain, cholangitis. What is the classical triad of cholangitis? Pain, jaundice, and no mass per abdomen. Okay, so that is mostly seen in children, and it's very uncommon, right? In adults, they mostly present with abdominal pain, biliary stones, cholangitis, malignancy. By the time we actually detect them, they almost have hepatolithiasis, cholangitis, CBD stones, malignancies, cholangiocarcinomas. So that's why, that is the importance of detecting it early. Even though it's very uncommon, they often present to us in a very later stage. Treatment is fairly simple. Yeah. So before the treatment of choledochal cyst treatment is mainly surgical. You all know that. We excise it and we anastomose it, bilioenteric anastomose, right? So before you go ahead with surgery, there's certain things to take care of is to delineate the extent of cystic process. What do I mean by this? So if you have a 4B cyst, it is of paramount importance to take off the whole cyst, like to remove the whole cyst. If you're leaving a part of the cyst in the intrapancreatic portion, do you understand what I'm saying? Like if you leave off a part of it on the MPD, then that becomes a problem. So that is why we need an MRCP to delineate the ductal anatomy. You have to find out if there is any pancreatic biliary malunion or a divisum or any such distal pathologies that is causing it. And you have to delineate the extent of the cystic process. And most importantly, you have to treat cholangitis. Cholangitis, pancreatitis, any sort of infections that they're present with, you have to make sure it's treated first before you go ahead with surgery. So this is type 1 choledochal cyst, right? So you do a complete cyst excision with a bilioenteric anastomosis. What are the different ways of doing a bilioenteric anastomosis? Louder. Choledochordianostomy? Roux by HJ, yes. If there is Roux by HJ, there is loop HJ, right? And then HD, hepaticoduodenostomy. And there are other methods also which are no longer used. Cyst extending into pancreatic head, you have to see on table. Like if it's going into the pancreatic head, you might even have to do a pancreaticoduodenectomy. You should look at the patient's status and all that before deciding that. Okay. So, what do you think will be the advantages with doing a hepaticoduodenostomy with respect to a hepaticojejunostomy? Yeah, it is more physiological. Yeah, hepatoduodenoscopy is more physiological. Yes, and is it a simpler procedure? It is. It is actually a simpler procedure if you do a liberal cauterization and all that. In where duodenum can't be pulled up like nicely to the CBD area, then it becomes difficult. So hepatoduodenoscopy is a much simpler and a physiological method. The recovery will be faster with a lower hospital stay and time to refeeding. So so HG is mostly done Rho and Y, right? The problem with hepatoduodenoscopy is that you can see there is reflux of contents. There is reflux of contents in cholangitis, and they propose that the risk of cholangiocarcinoma might also be higher, but that is not exactly proven. So the problem with HD, that is biliary gastritis, cholangitis, and all that, can be mitigated if you do a Rho and Y HJ, like we do a Rho and Y GJ. The reflex is less, but there are certain issues with HJ, that is longer operation theater time. So hence the recovery and all that will be delayed. Also more reoperations. More reoperations, why? Anyone? No, we have taken care of the jaundice, HJ. Yeah, stricture then. No. And also adhesive interstitial obstructions, right? Interstitial obstructions, more handling, and adhesive interstitial obstruction, all that is more with HJ. And when duodenum is not easily accessible, you can go ahead and do a HJ. So this is one method that was used previously. It's a choledocholecystodiodenoscopy, no longer used. This is what we just talked about. Type 2, it's just a diverticulum like a GB. You basically remove it like a simple cholecystectomy. Based on what the neck diameter is, you can just cut it off, ligate it off, or primarily repair it with or without a T-tube. This is a choledochal cyst. Okay, this is one of the most uncommon variants of choledochal cyst. So when we treat a choledochal cyst type 3, what you have to keep in mind is that the risk of malignancy is very, very low with type 3. Okay, so it's extremely rare and the risk of malignancy is also low. So what we do is, so we have multiple options. Endoscopic options being sphincteroplasty with cyst excision, unroofing. The same things can be done open or transduodenal. Even ripples can be done. So this is like an algorithm proposed by Lobeck et al. In one of their papers. What they have shown is somebody who is presenting with a suspected choledochal seal, you see the size of the cyst. If it's more than 3 centimeter, then you intraoperatively you explore and you find what kind of epithelium they have, right? Biliary is supposed to have more risk of malignancy than intestinal. So if it's intestinal, you can still do a subtotal cyst excision or a sphincteroplasty, much more conservative line of management. And if it's biliary, or if the cyst is, so if the cyst is more than 3 centimeter and it has biliary epithelium, more high risk factors, PD. If it is less than 3 centimeters, you can go with endoscopic methods, or again, like a more conservative subtotal cyst excision. Type 4 cyst, we cannot just manage like we do all with the extrahepatic. Why? Because it has an intrahepatic components. It has the complications associated with it, like hepatolithiasis, cholangitis, strictures, cholangiocarcinoma, etc. So it mostly always will have some sort of liver resection with it. Type 4B can be managed like a type 1 cyst. So type 5 is a Caroli's disease. This is Caroli's disease, okay. Caroli's syndrome is slightly different. Caroli's disease, when combined with congenital hepatic fibrosis, that is called Caroli's syndrome, right? It may or may not have other cystic diseases like polycystic kidney disease and all that. There is a diffuse form, there is a focal form. Liver biopsy is not required to diagnose Caroli's disease. I would like to stress on it, but it is useful. Why? Because we can detect CLD features like fibrotic features, epithelial dysplasia, or malignancy if they already have it. So what is the treatment for Caroli's disease? It will be a multidisciplinary approach. If it's a focal disease, you can go ahead with endoscopic or IR approaches, that is to treat cholangitis and other problems. If it's a diffuse disease, you have to do surgery. Liver resection is seldom possible, so it's mostly orthotopic liver transplantation. That is the final, definitive treatment for Caroli's disease. Biliary drainage, as you all know, most of these, like I said, they will present with cholangitis, hepatolithiasis, and things like that. So endoscopic removal of the stones, ERC, stenting, PTBDs, all these are like very crucial in the treatment plan. So if you have a case of Carley's disease, it's an elective case, diffuse full involvement or end-stage liver disease, transplant, right? If polycystic kidney disease is also there, then you go ahead for a concurrent hepatorenal transplant. If it's an emergency, you treat the jaundice cholangitis with endoscopic approaches, and then you see if it's a diffuse or a segmental, then you go ahead with the same kind of treatment. I want you guys to look at this and tell me what sign I'm showing, radiological sign. What? Anyone? We are running out of time faster. These are the cysts, and you see these enhancing dots inside. These are the stones. These asterisks are the stones. These are the dilated cysts. These are all enhancing things inside. It's a central dot sign, okay? So these are enhancing portal radicals surrounded by the dilated cysts. This is like pathognomic of Carol's disease, okay? Central dot sign. So, can we do a laparoscopic repair of colorectal cyst? Yes. Less pain, less recovery time, all the usual things we cite for laparoscopic repairs. And especially if the patient has had recurrent cholangitis, we expect some sort of difficulty in dissecting the cyst of the hilar structures, portal vein, hepatic artery, etc. There, the visualization becomes important, and that is much more superior with a laparoscopic approach. Better magnification, easier, safer dissection. Okay, but the problem is you need expertise, and it is much more challenging. This study has literally shown that robotic repair has all the benefits that we can have. Slowly, with advances in robotic and more accessibility to it, we'll probably be doing robotic repair routinely. Yeah. Okay. Any doubts? You stay clear of it. You obviously the cystic process, you stay clear of it. The neck is too wide and you think it's going on for a minute duct. You will take a part of the duct, right? So, sorry. You take out the whole pathology. Recurrence is not a known thing because type 2 itself is extremely rare. Okay, recurrence is not commonly reported, and you excise widely. So if you are having to take a part of CVD with it, you repair it primarily or repair it over a T-tube. Recurrence is not a concern. Yeah. Diffuse is more than 2 segments. More than 2 segments.
Lakshmi Satish.
Thank you.
I request Dr. Anjalin Raju to felicitate Dr. Lakshmi Satish. I request ma'am to felicitate Dr. Laya. Next, we'll go on to the case report presentation. And the judging faculty for this session will be Dr. Anjalin Raju, Dr. Venkatesh, Dr. Ravi Shankar. And the first presenter will be Dr. Sai Ganesh.
Timing 7 minutes plus the next discussion. Any timing beyond 7 minutes will be stopped. 2-3 minutes discussion. 3 minutes only. Okay, strictly adhere to the timing. We request the presenter to be strictly adhere to the timing. 7 minutes for presentation, 3 minutes for discussion.
Special instruction to all the presenters. Kindly adhere to the timing of 7 plus 3 minutes. 7 minutes of your presentation and 3 minutes of discussion. Any presentation more than 7 minutes will be stopped. Our first presenter for this case report presentation will be Dr. S. Sai Ganesh on the topic of rare case of extra mammary Paget's disease. No time. Dr. Sai Ganesh is there.
Kaushik.
Good afternoon, everyone. I am Dr. Sai Ganesh, second year postgraduate from SWIMS Tirupati. So I am presenting a case of extra memory Paget's disease. So usually Paget's disease of breast is a superficial presentation of ductal carcinoma, but whereas extra memory Paget's disease is a primary disease originating from epidermis. It is an intraepidermal adenocarcinoma, which usually occurs in sites rich in apocrine glands such as axilla, genital region, and perineal regions. In 25% of cases, it may be secondary to underlying carcinomas in genitourinary and gastrointestinal tracts. It usually presents as an erythematous plaque. So this may misguide our diagnosis because it has similar presentation to other dermal conditions like eczema, bacterial and fungal infections. Usually these patients tend to present in dermatology OPD with complaints of erythema and rash. So patient would be treated on local steroids or antifungals, antibacterials for a long period of time, and there is a high chance of a disease progression due to delay in diagnosis. So here, this is a case of a 72-year-old male presented with an painless ulcer in the left groin region, with bilateral groin swellings. On local examination, there was a pale-colored ulcer of size 2 into 1 centimeters with rolled-out margins. Bilateral inguinal lymphadenopathy was noted. On ultrasound examination, there was a bilateral lymphadenopathy, and know that secondary tumors were found or any metastasis was noted. PET scan revealed only inguinal lymph nodes and with no other metastasis. There was a bilateral inguinal lymphadenopathy with left ilioinguinal lymphadenopathy. So patient underwent wide local excision with inguinal lymph node dissection. Initially, patient was diagnosed as squamous cell carcinoma from FNAC from bilateral groin lymph nodes and from edge biopsy. But later on, after wide local excision and immunohistochemistry, patient was diagnosed to have extra memory Paget's disease. So usually, extra memory Paget's disease immunohistochemistry stains include CK7. This may be positive in a secondary extra memory Paget's disease. Usually, CK20 is negative in primary, whereas it is positive in secondary disease. Musicarmine and pastain are used for mucin staining in Paget cells. So Histopathology slides showing the signet ring cells in the first two slides, and VC carbon stain and pass stain for staining the mucin in the Paget cells. So usually it is a in histochemistry we can only differentiate this from other carcinomas like Bowen's disease and superficial spreading melanoma. So usually when coming to management of this disease, patients presenting with erythematous rash in areas rich in apocrine glands, usually like in axilla or groin, usually treated with antifungals or steroids. On if there is no improvement, we can go for biopsy. Then for biopsy and immunohistochemistry staining. After confirming our diagnosis as extramemory Paget's disease, my wide local excision of the disease of the ulcer or whatever the carcinoma is involved is resected. If in unresectable cases where there is more spread, trial of chemotherapy or radiotherapy can be done, but that also efficacy remains good. Usually, to rule out secondary EMBD, pelvis, abdomen imaging, colonoscopy, etc., should also be done. And close monitoring of patient for up to 10 years is needed, as the recurrence rate is up to 30 to 40% after a wide local excision with negative margins. Thank you.
What was the margins which you gave?
Actually, intraoperative frozen section showed positive margins on basal side. So, redo surgery was also done for this case. Usually recommended more than 2 centimeter free positive margins is recommended for this case. Yes, ma'am. Later, yes, ma'am.
H biopsy report, it was given as a squamous cell carcinoma.
Squamous cell carcinoma, they are reported as a squamous cell carcinoma.
Was it well differentiated or poorly differentiated?
Poorly differentiated squamous cell carcinomas. FNAC also they have given metastasis from squamous cell carcinomas from lymph nodes.
No, that is okay. FNAC from lymph nodes, okay. What is the primary biopsy report?
They have reported as squamous cell.
What is most surgery?
Microscopic resection of tumor until we get negative margins.
Was it tried in this case?
No, sir. When they went for the wide local excision.
Can you show the clinical picture? So, sorry, since this is award paper, we need to be clear on certain things. So this looks like more of a scrotal malignancy with inguinal metastasis rather than an extramammary Paget's disease. Extramammary Paget's disease can be of two types, as you mentioned. That actually takes a long duration to go into a transformation to secondary malignancy, or it can be external representation of the internal malignancy. As those looks like a more of a straightforward scrotal squamous cell carcinoma with internal metastasis. 1 point. But if this is the case, why the PET-CT is not the first investigation of choice?
Other investigations were also done, sir. No intra-abdominal malignancy or any other thing was found in that.
But PET-CT need not to be the investigation of choice in this category. Can you come to the histopathology? Histopathology, there is a mention Hutchinson cell.
Yes, yes.
So the sickness sense is typical of intra-abdominal.
So signal cells is a primary characteristics of intra-abdominal malignancy. You might have to go back and discuss with the pathologist the significance of the signal cell. Is it just a signal cell, or is it a signal cell malignancy, or something? You have to be very, very careful when you talk about this. This looks like a scrotal malignancy. I don't think that it could be called as extramammary Paget's disease.
So initially it was managed as a squamous cell carcinoma of scrotum. So
It is squamous cell carcinoma.
but on immunohistochemistry later,
They usually occur at the orifices, particularly around the anal ridge.
They do not present like this ulcer. They present like a superficial break-like lesions around the perianal region or around the venous region. So that is the exact characteristics of it. If you Google it and see the images, you can see the various types of extramammal. This is not extramammal. But of course, scrotal malignancy itself is a rare thing which is acceptable of this presentation. But there is a disparity between the topic and the clinical diagnosis and also the histopathology diagnosis.
okay. Thank you, sir.
I'd like to call upon our next presenter, Dr. Parth Maheshwari, on the topic of gossipoma, a nightmare of a surgeon.
So good afternoon, everyone. Good afternoon, judges. I'm Dr. Parth Maheshwari from Department of Surgery from AIIMS Rishikesh. Today, I have got this golden opportunity to present my case report in front of you. Its topic is gossipoma, a nightmare of a surgeon. The co-authors are me, myself, Dr. Manish, Dr. Vidyacharan, and Dr. Sudhir Kumar Sen. Okay, so starting with the introduction, what is a gossipoma? The gossipoma is basically a mass forming around a surgical sponge that is left inside accidentally during a surgical procedure. And this gossipoma is this amalgamation is generally derived from the word gossypium and boma. Gossypium, which means a cotton sponge or a cotton thing, and a boma which means a hiding place or a concealed place. So it is basically a cotton or something that has been hidden somewhere in the body. This gossipoma can present in a variety, variable fashions. Some of the most common presentations are, it can present as an obstruction, it can present like peritonitis, adhesions, fistula, abscess formations, erosion into the gastrointestinal tract, and it can even, in some of the case reports, it can even reported that it can pass through the rectum. It is a very rare event, and this is mostly we can understand because of its underreporting, because as it can lead to many medical level issues, and it can also call upon critical press coverages. These gossipomas are mostly found inside the abdomen, but they can be seen in any cavity of the body. It can be found in the pelvic cavity, in the thoracic cavity, even some of the cases it can be found in the cranium. It is most commonly seen after the cesarean section and open cholecystectomy, as in this case also. So starting with my case report, my case report is an old gentleman. He is in 40s. He came to us with the complaints of abdominal pain in the right flank, which was insidious and onset, gradually progressive, non-radiating pain, which was relieved on medication. And he also complains of the multiple fever episodes, which was on and off, and it was relieved on medication for the past 7 months. On history, he said that he underwent an open cholecystectomy 7 months back in an outside hospital. When patient was examined, on examination, a weak lump was palpable in the right flank region, which was ill-defined in margin, firm in consistency, and it was not moving with the respiration. A further evaluation of the patient, CT scan was done, and initially the diagnosis was suspected, as it was a right flank mass, the diagnosis was suspected to be renal mass. But on CT, it was found that there is a heterodense lesion with multiple air foci and enhancing wall in the right lumbar region, which was approximately 8 into 9 into 9 centimeter, and it was abutting the transverse colon and ilial loops, with also luminal communications were present. Patient was taken into emergency OT, and an exploratory laparotomy was done with primary repair of that transverse colon fissure rent, with removal of the intra-abdominal gossipoma and the resection of the abscess cavity which was formed around the gossipoma. And the bowel which was adhered to the gossipoma was resected. Approximately 20 centimeter of bowel was resected. The distal jejunal anastomosis was done, and proximally double barrel jejunostomy was taken out. On post-operatively, patient was extubated, and on the POD2, he developed a high output stoma. It was a proximal stoma, so he was managed on the TPN and low residue diet. Patient also had SSI on POD, because of which on the POD9 he developed a burst abdomen, which was managed by applying a laparostomia bag, and he also underwent the 10 cycles of HBOT. He was discharged at a vitally stable state on a POD30. So now coming to my discussion, basically the gauzy boma is a nightmare for a surgeon, as the topic suggests. This gauzy boma, there are several risk factors because of which this happens. The major risk factors, as we can understand, is mainly because of like midnight emergency surgeries when the surgeon is very tired, wetty, and can't concentrate over the surgery. The surgery is with the heavy bleeding, because during the heavy bleeding we uses too many of the paws or more pieces are being used, and some of which might have left inside. If there are long hours of surgery, if the entire team is fatigued, if there is unplanned changes during the operations, then it is a high risk factor. And it has also been found that patients with the high body mass index, in those patients there is a high risk of gauzy boma being found. So now, as gauzy boma is, and as we can understand, the gauzy boma is a preventable risk factor. It is very deteriorating for the patient, so it is very important to take steps to prevent it. So what can be the preventable measures for it? So first of all, the most important thing is a count to be done in the various phases of surgery. The American Society of Nurses recommend this very highly, that this count for the gauge pieces and knobs should be done at various phases of surgery, like before starting of the surgery, during, like even if a single gauge pieces or mop is added, the count should be repeated. It should be done before the closure of the rectus in an expanded laparotomy, and also before the closure of the stem incision. The optimal environment inside the OT should be maintained so that a surgeon and the operative team can focus on the operative task. The surgical safety protocol should be implemented in every institution, and it should be also included in the curriculum of surgical residency, and even the training of anesthesia team as well as the nurses. These proper guidelines should be there to inculcate a proper method of counting the surgical sponge and instruments. Exclusive usage of mop and gauze pieces with the radio opaque marker should be used, because radio opaque markers can help us to identify these gauze and mop pieces intraoperatively just after the OT by using a simple CR. So coming to the conclusion, simply that National Quality Forum of USA and Health Department of UK have declared the presence of retained gauze sponge as a never event. It should never happen that a gauzy boma should be left inside or a cotton swatches, but there should be steps to prevent this. And so as it causes a significant morbidity to the patient and additional cost of redo surgery with various medical legal issue. As you can see in this case also, a patient underwent a simple open cholecystectomy, but after 7 months he has to undergo these kinds of surgery, through which he developed the SSI laparoscopic bag was put, then he had developed hyospostoma, which resulted in his morbidity, increases the cost of the surgery, as well as he has his hospital stay. So these are my references. Thank you.
Put that slide where you put materials and methods. The slide where this is a case report. No. Materials and methods.
Yes.
The previous one. Case report, there is no need to tell materials and methods.
Sorry, ma'am. Yes, ma'am. Title should be changed.
Sorry.
Okay.
Just informing you.
Yes.
For a case report, you need not get into that template.
Okay.
Number two, why BMI is a big issue?
BMI is a big issue because as there is a lot of fat content, so it is very difficult to talk. Like if we are using suppose simple gauge pieces or counts, so it might be remain inside because of large abdominal cavity, abdominal space of the patient.
It's because there is a cavity under the subcutaneous fat.
Fat, yes.
That is why BMI patients, you see them huge and they need the guiding state.
Yes, ma'am.
To be careful, number one. So that is the idea of BMI, not abdominal cavity. Abdominal cavity full of visceral fat. There is nothing to accommodate.
Okay.
Skin will be a problem. And most of the time your support staff will be very angry. After closing peritoneum, you again want the count.
Okay.
Lot of rebel will happen at the supporting end. It's not that easy.
Yes.
We can put lot of rules here.
Yes.
The problem will happen at the supporting end because the supporting end is never hauled up by the courts ever. It is a surgeon.
Yes.
So you need a lot of time to get that supporting team on the same page.
Hmm.
Number one. And number two, they will object. I've already closed the abdomen. You're again asking for for a
For
count. So you need to use your time appropriate for that facility.
communications.
And
Yes.
something else I want to ask. Yes, it's a very practical problem. What if the nurse tells you, I've got more time than what you put inside? Doctor, now I know I put 10. Now the count is 11. We have had these practical issues. They are not hypothetical.
Ma'am, then actually this problem can be solved if, like in the starting of the surgery, the number of counts and gauge pieces have been.
Scenario. I'm giving you a scenario. I'm not talking about how you do it. I'm giving you a
Okay.
scenario that's happened. Nurses will tell doctor, I gave 9, but now 10 has come. I'm getting one more extra.
Will ask us to recount.
Yes. Then come again
Definitely.
with that.
Yes. And
Then the same thing.
okay. And we'll once explore the abdominal
More a
cavity.
difficult problem
Yes, ma'am.
than a lesser count.
Mhm.
Lesser count, it's with you. You can handle it. You can get the radio flows inside, take an X-ray, or dig into the abdomen 10 times.
Yes.
But this problem has gone beyond you. If you go to the CSSD, those will supply the dose.
Yes, ma'am.
You got my point, it's a big administrative loop after that. So you take enough precautions that the moment they tell you more counts, that means there is a big problem going on. Do everything possible to make sure there is no reclaim cause or whatever. Don't be happy.
Yes,
They are
ma'am.
giving more counts than what they put in. No. It means that means things have gone terribly wrong. You do everything properly and involve the administrative setup. They have
Okay.
their own ways of following the trades. How to sort out where to fix, if at all they can fix.
Okay.
You got my point?
Yes,
That is important.
Sure. Okay. Thank you, ma'am. Acha. Sorry.
Why you had to go for a proximal double barrel jejunostomy?
Sir, actually, intraoperatively, it's what found that where the gossipoma was, there was 2 loops of jejunum which was adhered to it, and in both there was luminal communication and an abscess was formed around it. So while taking out that abscess and gossipoma, we have to resect the jejunum at 2 sites. One was 150 centimeter from the DJ junction, and this was 130 centimeter from IC junction. So approximately 20 to 25 centimeter of bowel was resected, and there were 4 means like there was a proximal means resection was also done, and distal resection was also done. So distally we did the jejunal anastomosis, and the proximal was taken out as a stoma. Yes, ma'am.
Number one, they land up in the government hospital at the end. You know, they land up there, and then there's such a cavity, you keep on chopping. At least you'll be happy you got an even number of openings. Sometimes we have got the odd number of openings. We don't even know where we were. We have had these issues before. And one more thing, what are the medical legal complications of breathing sponge?
Ma'am, it can like a person, it is actually a criminal negligence. Basically, the patient can take us to the court, and then it would be difficult to defend it by instrumental.
How do you record it with the patient?
Means if a patient has came out from outside.
Or
Okay.
in your own institute?
Like we report it like there is a system of like making a means medical legal number we give to such kind of cases, and then it has been there is a diary through which we give a medical legal numbers, and this has been handed over to the police station.
You record in your patient, there was this loss found this time.
In
The documentation made.
in this case we did it.
Photograph done.
Yes, ma'am.
Yeah, now we have to do the photograph also.
Documentation was done.
That is important.
Yes.
You may not actively pursue the previous surgery, but the information has to go
Has to go.
where it has to go.
Yes, ma'am.
That is important. You may not, that is not your business to pursue the negligence, but your part also should be clear cut. And one more very simple thing I'll tell you. The problem in the retained sponge, there's a lot of layman publicity. Everybody will jump into it. You can do a GJ very badly and kill the patient. Nobody knows. You can reverse the loop and kill him. But when there is a sponge, the whole thing, the whole hospital, the whole community will be having like the press and everybody comes. So there was a little practical tip we were taught by our seniors. If you see a gauze retained there, ask staff for another gauze. Don't make a big advertisement there. No need. The problems will happen at the supporting staff level. It is never at the doctor's level or the anesthetist level.
Yes, so true.
Don't make a scene. They have no clue what's going on in the apple. Ask for a big gauze. Put it there and take
Take
this
it
gauze
both
and put it in the dustbin. You know that the gossifier mark came out right in your notes. Because
Yes,
after this poor stoma leaking here and there, you will also have a headache because the issue has moved out of your institute now.
Yes.
That will be more of a headache than handling the TPA. Got my point?
Yes.
These are very practical things. You pray to God that you don't get into this situation. But if you do get, this is a practical solution.
Okay. Okay.
Who communicated with the patient? Because many times all these issues might happen where you communicate to the patient. Well, always the senior person has to communicate with the patient, and it's because one of the places they went back to the surgeon and they caused lots of problem there, even damage and all those issues. So these cases have to be managed very, very carefully by the senior person in the department or in the unit, and that has to be managed carefully with the communication. Communication is the main problem. The complication is the second problem. It's easier to write a gossip or a paragraph found inside, but to be very frank, you say the gossip was underreported. Why? Because it's always many senior professors, they try to save many of their colleagues and juniors by not reporting it on the case sheet, although it's not the scientific content of this, but many senior professors, their juniors, their colleagues, they opened up the abdomen, they removed it, they just documented as abscess, just finish the matter. That is the reason why it's underreported many times.
Yes, sir.
One main issue is keep the supporting staff outside this discussion.
Yes, sir. Yes, ma'am.
That is very, very important. They have no accountability and they love to gossip. See, the fellow taking out the gauze also has a lot of responsibility. You got my point?
Yes, ma'am.
The surgeon who's going to take out the gauze also, his head is on fire. So keep the supporting staff out of this.
No, but it's not only the big cavities. I have seen gauze in the thyroid bed.
Yes,
I have seen gauze in the varicose vein incisions.
Okay.
These are very common. The pad, many times what madam said, no, that take a large pad. Many times it's very difficult to hide the pad. So what the surgeon does is take the big gloves. He wears two gloves. Take and just put it inside, and actually he goes with the gloves. So many times it happens. These all things that happen as long as it is basically to safeguard our colleague if it is feasible. But it is well known, the radiologist has documented the patient communication. No, there is no factor to hide. You have to document.
Yes, sir.
One more thing, what ma'am told, we have to usually follow the numbers at least like every 3 mops, or at least if major cases are 6 mops, every time you take only 6 mops, so that the counting does not confuse you.
Yes.
Either it should be 3, 6, 9 or 6, 12 like that. So if you take one mop by one, then there is a chance that, as ma'am told, there might be miscommunication. I gave whether 9 or 10, we don't know. So it has to be in multiples of 3 or 6.
Yes.
Yeah, that is another way to prevent this.
Yes, sir. In our institute,
The WHO safety
it can be there.
is very important. Those are the things to, stop you from doing this preventable errors.
Errors. Yes, ma'am.
That is not for you to do the right teaching. That is to prevent preventable errors.
Yes.
And one more thing is, when you are handling this case, I know it would have been because of so much of abscess and that, but we have to be very careful in taking out that loops so that to avoid these type of injuries very carefully. Because already patient is a medical legal issue case, so we should not again complicate more with that.
Yes, sir.
Dr. Park. I would like to call upon Dr. Tripta Ramya Sahu to present challenges of extrahepatic fistula sequential to hepatic iridosis biliary fistula case report.
Good afternoon, everybody. Today I'll be presenting my case report on the challenges of extrahepatic complications sequelae to hepatic hydrated cystobiliary fistula. So, the incidence of hydrated disease in our country is about 1 to 100 per 1 lakh population, and about 75% of these occur in the liver. Of these, about 2 to 11% of hepatic hydatids are found to have an underlying cystobiliary fistula, and about 5 to 30% of these identified cystobiliary fistula are often post-surgical complications. So there are many methods of management of this. So one is medical, endoscopic, percutaneous, and multiple surgical options are also available, like percutaneous, hepatic choledochostomy, pericystectomy, and hepatectomy. So the first case here is that of a 41-year-old female who was diagnosed with a right hepatic hydatid cyst in 2016, and in 2017 she underwent a pericystectomy and omentoplasty for the same. In 2018 she was diagnosed to have a biliocutaneous fistula, for which she underwent a biliary fistula repair with cholecystectomy. Following which, again in 2023 she presented to us with right hypochondriac pain, jaundice, and high-grade fever, and she was diagnosed to have cholangitis of an obstructive cause with a biliocutaneous fistula which was recurrent. So she was evaluated, investigated, and on the imaging on MRCP, she was found to have a biliary stricture at the confluence of the right and left hepatic ducts in the proximal CBD, with gross atrophy of the right lobe of liver as shown in this MRCP. Along with that, there was bilobar IHBRD with multiple intrahepatic hepatolithiasis. So she was first stabilized with antibiotics, following which a percutaneous transhepatic biliary drainage was done. Following that, she underwent the definitive procedure of hepatolithotomy with Roux-en-Y hepaticojejunostomy. Intraoperatively, multiple stones and sludge were retrieved from the left duct system, and she underwent anticolic site-to-site single-layer hands-on Roux-en-Y hepaticojejunostomy. And post-operatively, the PTBD was left in situ, and there was decrease in the drain output eventually. And after 3 months, there was complete resolution of the jaundice and the biliocutaneous fistula. Coming to the second case report, this is that of a 55-year-old male with who presented with a type 4 calcified hepatic hydatid cyst of right lobe of liver, following which he was managed with serial percutaneous catheter placements till June 2023 for infection of the hydatid cyst, secondary infection. In June 2023, the patient presented with cough and expectoration for 2 weeks. On evaluation with a bronchoscopy, bile reflux was seen from the right anterior basal segment, and the patient was diagnosed to have a bronchobiliary fistula. And following which, initially for biliary decompression, ERCP was done. With ERCP, there was resolution of the bronchobiliary fistula eventually, but the patient again came with abdominal pain, fever, and vomiting. Patient presented in sepsis with increased pus discharge from the percutaneous catheter site. The patient was evaluated with imaging. On CECT, he was found to have a calcified hydatid cyst in the segment 6 and 7 of liver with a subdiaphragmatic collection as noted. There was a persistent of the bronchobiliary fistula tract, and the pigtail catheter that was in situ for this patient is also noted here in imaging. So this patient was again stabilized, and he was managed for the sepsis with intravenous antibiotics. He was nutritionally improved. All resuscitation was done, and finally for source reduction here, the patient underwent an extended right hepatectomy. So intraoperatively, a calcified cyst was found to be occupying the right posterior segments, and bile staining was noted, and liver parenchyma was transected lateral to the falciform ligament. This is the postoperative specimen that is noted. The calcified segment of the hydatid is also noted here. Post-operatively, the patient's biliary leak resolved and the patient improved symptomatically. And post-operatively, the collection also gradually reduced within 3 months time. This is the intra image for the patient. So here, behind any hepatic cystobiliary fistula management, these are the objectives that we have. That is elimination of the source, the parasite, the treatment of the pericyst and the residual cavity to avoid secondary infections, and also removal of identification and removal of any cystobiliary fistula that might have been existent there. So here in the first case, we have seen there was sequential application of multiple surgical procedures like pericystectomy and Roux-en-Y hepaticojejunostomy that was done. And in the second case, ERCP was initially done for biliary decompression, but the patient's symptoms did not completely resolve. So we had to do extended right hepatectomy for the source reduction. So from these two case reports, the things that I would like to highlight is, one is a lot of in surgical procedures of any hepatic hydatitis, there is high morbidity and mortality. So there should be early identification of any underlying cystobiliary fistula through adequate imaging, so that we can avoid any extrahepatic complications that may manifest later, increasing the morbidity and mortality. And also we should identify when we should identify and do a careful evaluation as to when the patient would need surgical management, and do it as soon as possible. Thank you.
Is there any way of preoperatively finding these connections?
Yes, ma'am. Preoperatively, we can evaluate the patient with an MRCP. Like if suppose we are suspecting from the CCT or ultrasound, then we can do an MRCP for this patient. Very often we don't end up doing it. That's why we miss the cystobiliary fistula.
Any way of intraoperatively finding out?
Yes, ma'am. Intraoperatively, we can do an intraoperative cholangiogram. Then we'll be able to identify. Or ICG dye can also be used, but more commonly cholangiogram is performed.
What are the cysts where you expect a biliary connection? Are there any risk factors for the cyst?
Yes, ma'am.
Regarding the size or the place?
The location of the cyst is important. If it is close to the gallbladder bed and if it is closer to the hilum, there is a higher risk of cystobiliary communication be found. In those cases, intraoperatively, we have to be careful, and we often do after pericystectomy intraoperative cholangiogram in such cases to identify if any fistulous cavities, fistula tract is missed.
The first case there was a stricture.
Yes, ma'am.
Was it iatrogenic?
It could have been, actually, ma'am, she had multiple surgeries she had undergone. So it is very difficult to identify at this point where she came after 2 surgeries, whether it was iatrogenic or whether it was due to hepatic hydatitis as such. Because she underwent a pericystectomy, after that a fistula repair with a cholecystectomy. So we cannot say at this point if it is due to the hepatic hydatitis or if it is due to postoperative.
Hepatic hydatitis by itself causes stricture in the bile duct?
It can cause inflammation, sludge. It can cause, ma'am.
Yes, ma'am. Actually, I don't think by itself it can cause any stricture. No, it cannot cause a stricture. You told now preoperatively you will do an MRCP. Is there a better procedure or investigation you can do to evaluate this fistula preoperatively? Can be therapeutic also to avoid such complications.
ERCP can also be done.
So ERCP, such a fairly large cyst, if you can go ahead and do a ERCP, it is both diagnostic as well as you can put in a stent also, so that the risk of getting this post-operative fistulas are very low. And you can prevent the cholangitis also. But I hope these 2 procedures are done in open surgeries only.
Both are open.
Yeah, both open. In case of laparoscopy, the risk is still more. If you think laparoscopy is still more, risk is more or less? The risk of the fistula and the cholangitis.
Not sure, sir.
Actually, it is becoming more because the pressure is more. If you don't decompress by this preoperative ERCP, it can precipitate in fistula and cholangitis. So preoperatively ERCP would have limited this risk also.
Just one last question. What was the reason for the first case? I just have a doubt. What is the reason for the right liver atrophy you mentioned? What was the reason for it?
Like the hepatic hydatitis as such could have caused a right liver atrophy in this patient, because she is having this disease from 2017, and for which so chronic inflammation atrophy is one of the reasons for this. Vessel as such, there was nothing identified. Like no issue with vascular. Thank you, sir.
Thank you. Next presenter will be Dr. Surya K. Presenting on the topic of neuroendocrine tumor of pancreas, masquerading as locally advanced pancreatic adenocarcinoma.
Good afternoon, sirs. Myself, Dr. Surya, Junior Resident in the Department of Surgery. I am presenting a case report on neuroendocrine tumor pancreas masquerading as locally advanced pancreatic adenocarcinoma. So, coming to introduction, neuroendocrine tumors almost can occur in any organ, and most commonly they have an incidence in the pancreas of less than 1%. And pancreatic neuroendocrine neoplasms per se are heterogeneous neoplasms which can either be functional or non-functional with neuroendocrine differentiation, and they show characteristic clinical, histological, genetic, and biological behavior. Coming to gastrointestinal stromal tumors, these are mesenchymal neoplasms that can occur predominantly in the stomach and rarely they occur in the colon. And they rarely occur synchronously with neuroendocrine tumors, especially associated with neurofibromatosis 1. Here, we report a case of neuroendocrine tumor pancreas, which had an unusual presentation, a long clinical course, and which had uncertain diagnostic uncertainty, which led to suboptimal care for the patient. So coming to the case, here it was a 53-year-old gentleman without any comorbidities. He presented to an outside hospital with a non-bilious vomiting associated with a dull aching abdomen pain for 15 days. He presented to outside hospital in November 2022. He was examined. The general physical examination was normal and per abdomen examination was also normal. And in view of non-bilious vomiting, he underwent an upper GI endoscopy where he was noted to have a narrowing at the second part of the duodenum, following which he was evaluated with the contrast enhanced CT abdomen, which showed a heterogeneous hypoenhancing mass lesion measuring 8.5 cross 4 centimeter, which showed central calcification arising from the pancreatic head and uncinate process, which was closely abutting the right kidney and IVC. Further, he was evaluated with suspecting adenocarcinoma of the pancreas. He was further evaluated with the tumor markers, which showed normal value. CEA and CA99 was normal, and his liver parameters were also normal. Considering a provisional diagnosis of adenocarcinoma of the pancreas, he was planned for pancreatic duodenectomy. But intraoperatively, he was noted to have a locally advanced disease, and a palliative biliodigestive bypass was done, where he underwent a loop gastrojejunostomy, cholecystojejunostomy with Brand's anastomosis was done, and intraoperatively a core biopsy was taken from the lesion arising from the pancreatic head. But the final histopathology report was inconclusive. That was, they were not able to come to a final conclusion whether it is an adenocarcinoma or not. But considering a provisionally adenocarcinoma, he was planned for a trial of neoadjuvant chemotherapy followed by reassessment. But the patient deferred further treatment and he was lost to follow-up, and nearly he had an asymptomatic course for about a year. Meanwhile, later he had recurrent abdomen pain for which he consulted nearby hospitals. Later, he visited JIPMER nearly after a year with for further management, since he again had recurrent non-bilious vomiting with significant loss of appetite. On presentation to JIPMER, that was in February 2024, around nearly 1.5 years after the initial surgery, he was evaluated again. At presentation, he was vitally stable. His liver parameters was normal. His tumor markers were normal. He underwent further evaluation outside the slide review as well as CT review was done, and he was further evaluated with CECT abdomen, which showed a homogeneous hypoenhancing lesion arising from the uncinate process of pancreas, which was closely abutting the right renal pelvis, right ureter, and IVC. Following which, he underwent PET scan, which showed a low FDG avid lesion arising from the pancreatic head, and there were no distal metastasis, and there was no significant regional lymph nodes also. In view of lesion arising, to take a preoperative tissue diagnosis, he was further evaluated with an endoscopic ultrasound, which showed a large heteroechoic mass lesion arising from the pancreatic head, and a guided FNAC was taken from the lesion, which showed a cluster of tumor cells with round nuclei and scanty cytoplasm, and they were not able to give a proper diagnosis, and the report awaited. Since the patient had an asymptomatic presentation, he had a homogeneous lesion with a long clinical course, and it was a heterogeneous mass, that is both solid and cystic component, and based on the clinical as well as the radiological imaging, we suspected SPEN, that is solid pseudopapillary epithelial neoplasm, and he was planned for a trial resection. Preoperatively, since the tumor was closely adherent to the right ureter and renal pelvis, he underwent prophylactic right ureteric stenting, and then he was planned for a trial resection. Intraoperatively, we could find a large tumor arising from the pancreatic head and uncinate process, and it was closely abutting the renal pelvis, right hilum, and it was adherent to the IVC. And in the image, you can see the tumor, the right ureter was closely adherent to the posterior surface of the tumor, and the dissection was started, and finally the tumor was dissected away from the ureter, pelvis, as well as from the IVC without any tumor breach with the help of urologist. And this is the post-operative specimen. And after resection, he underwent a redo anastomosis. That is, the GJ was kept as such, and he underwent hepatic jejunostomy with jejunostomy. Intraoperatively, we also found a small nodule which was noted arising from the transverse colon, which was sent for frozen analysis, which initially showed presence of spindle cells. His postoperative course was uneven full. He was started on a normal diet on postoperative 4, and he was discharged on postoperative day 7 with an uneventful clinical course. His final histopathology report was suggestive of a well-differentiated neuroendocrine tumor of pancreatic head, which had negative margins, and on further IHC staining, it was positive for CK, synaptophysin, as well as chromogranin positivity. For staging the tumor, the Ka67 mitosis was done, which was 4% Ka67, and the mitosis was 3 per 10 high power field, and the pathological stage came out to be T3, N0, and MX. That lymph nodes were also 4 lymph nodes are noted, and all were negative. And the nodule which was noted in the transverse colon deposit, which showed spindle cells with the bland nuclear chromatin, and they were positive for CD117, CD34, and DOG1, which came out to be positive for colonic cyst. And considering the low-grade nature of both the tumors, after multidisciplinary team discussion, he was kept under observation with regular follow-up. In view of rare occurrence of this synchronous neuroendocrine tumor with the colonic cyst, he was further planned for genetic testing. So the specialty about this case is that it had an unusual clinical presentation, as it is a non-functioning neuroendocrine tumor. Patient did not have any symptoms, and after evaluation also he had an asymptomatic course for about a year, and the biopsy was also inconclusive initially, and final histopathology came out to be a low-grade neuroendocrine tumor. So coming to discussion, pancreatic neuroendocrine tumors, mainly we classify based on the Ka67 proliferative index as well as the mitotic index, and the somatostatin receptor imaging has been very important in imaging pancreatic neuroendocrine tumors.
What is your staging for this tumor?
It will be stage 2 disease.
Stage T2?
T3, T3 and 0 M0.
M?
M0.
M.
What you would have done that you reopen again and still it was inoperable? What you would have done for this tumor?
Sir, we would have again taken another biopsy, followed by we would have done markers postoperatively. Since already the symptoms has been managed initially with the triple bypass, we would have again undergone with the proper biopsy, intrabiopsy, and then we would have.
No, the intraoperative biopsy that finally came as what you mentioned that it is a grade 2 neuroendocrine tumor that was locally advanced and still inoperable on the second time also. What is your plan of further management?
If it was a low grade neuroendocrine tumor, if it has come in the biopsy report that you have taken intraoperatively, then we would have planned for adjuvant chemotherapy, sir. Like
no, adjuvant is after the surgery. I'm talking is inoperable. So you have some SME involvement. Then you are not proceeding faster. How do you manage a locally advanced neuroendocrine tumor which is not operable, or patient is not fit enough for the major procedure?
We can do whether we can find out whether it's a functioning or a non-functioning tumor, sir. We can do somatostatin receptor scintigraphy test like Dotanac scan can be done, 68 gallium Dotanac scan. If there is if it is a functional tumor, then we can go up with the octreotidal androgen therapy. And if it has been responding after the surgery, then we can go for trial resection again.
Okay.
The drug of choice for neuroendocrine.
Somatostatin analogs are the drug of choice for neuroendocrine tumors if they are functional tumors. Non-functional tumor, various regimens are sunitinib can be given, and recently temozolomide, all the drugs can be given. Yes, ma'am.
What do you think when the first intervention was done? What is unusual in that presentation? What was against the diagnosis of adenocarcinoma of the pancreas? in the picture. you-
Jaundice patient did not have jaundice.
Yeah, that is one. Then
Tumor markers were also not elevated.
so both the things. So when it is unusual, then it's better to go with a US guided FNAC before intervening such a major procedure. That is one thing. Then one more doubt I have is why this US guided FNAC was not still, like you told, it is avoided.
Sir, actually,
Even though the surgery is over.
Yes, sir. After later they reported they could find only cluster of cells with the round nuclei and cytoplasm, but later after the final histopath they correlated and they reported as neuroendocrine tumor, sir.
Then you can put that report only, no? Why don't put avoided, huh?
Yes. Thank you, sir.
Our next presenter will be Manish Kulshrestha on the topic of pancreatic ductal adenocarcinoma masquerading as chronic pancreatitis.
Good evening, everyone. Good evening, my fellow.
I'll stick to 5 minutes time, no?
Okay, yeah, I'll stick to time. Yes. Good evening, everyone. Today my topic is pancreatic ductal adenocarcinoma masquerading as a chronic pancreatitis, a surgical dilemma. My name is Dr. Manish Kulshrestha, and the authors of this paper is myself, Dr. Satish, RSR, Dr. Deepak Rajput, and Professor Amit Gupta, and our affiliation is from Department of Surgery in Rishikesh. So in the introduction, we can, as we all know, that pancreatic ductal adenocarcinoma accounts for more than 90% of all pancreatic tumors. Accumulating evidence shows that pancreatitis is a risk factor for development of pancreatic ductal adenocarcinoma, and around 5% of patients with chronic pancreatitis will develop adenocarcinoma within a 20-year follow-up period. Although some studies also suggest that as the follow-up period increases, the incidence comes down, but it's still there. And certain adenoma carcinoma sequence have also been discussed. Although in this case, also 30.8% of patients with CP who underwent surgery had synchronous PDAC, and this was an intra finding. So this is a similar case in which we can see, again, forgive me for this title, it is a case report. We are starting with a 49-year-old gentleman with type 2 diabetes, and he's taking OHX, and he presented to our OPD with 18-month history of pain in the upper abdomen, with associated with foul-smelling frothy stools, weight loss, and a 7-day history of callous discoloration of eyes. A physical examination revealed a solitary oval lump of size 5 × 3 centimeters in the epigastric region, a vague lump which was non-tender, found to harden consistency and not moving with respiration. And on further imaging, we can see that CT was indicative of a around 5 × 3.4 centimeter mass in the head of pancreas, along with uncinate process with gross dilatation of MPD, which is around 2.5 centimeters, with multiple 2.5 mm in the head, with multiple calculi within the ducts, and also multiple calculi in the head and body and tail. And in the distal CBD, there was more tapering and proximal dilatation of around 1.6 centimeters. We don't have the video, unfortunately, because the imaging got destroyed. But it was discussed with the radiologist, and it was suggestive of chronic pancreatitis itself, because there was no sign of any moving away of the calcifications, and also the smooth tapering of the distal CBD. So patient was planned for FRAIS with intra-op decision for a HJ if required. So patient underwent exploration, and intraoperatively multifocal hard lumps were palpable in the head and body of pancreas, and heavy lymph node burden was present at the splenic hilum, which was not evident on the CT. Frozen section was in the intraoperatively, we had aspirated the tissue from the mucinous tissue from the pancreatic duct, which was sent for frozen section. And in that, it was suggestive of malignancy, And thus, because of the multifocality of the lesions that were palpable intraoperatively, patient had undergone a total pancreatectomy with splenectomy, with Roux-en-Y hepatic jejunostomy, and gastrojejunostomy with feeding jejunostomy as a complete procedure. Final histopathology report was suggestive of multifocal, poorly differentiated pancreatic ductal adenocarcinoma of head and body with areas of mucinous and squamous differentiation, and a pathological stage of PT3 N0 was made, and 52 lymph nodes were there, and all were negative for malignancy. The patient was discharged on POD14 with prophylactic vaccination for splenectomy, and patient had completed 6 cycles of adjuvant chemotherapy with gemcitabine and capecitabine, and the patient is currently on follow-up, asymptomatic, and on PERT therapy and insulin therapy for the same. So as a conclusion, I would like to suggest that pancreatic ductal adenocarcinoma must be considered as a differential diagnosis in almost all cases of CP, because many a times if there are small multifocal lesions, they can be missed on imaging even after proper discussion, and that might not elicit further evaluation. When usually we go for evaluation when there is a doubtful situation in the CT. But in this, after discussion, since there was no doubt, we went ahead with surgery, and then intraoperatively, patient was had to be managed differently. So, a set of guidelines that can change the course.
Did you examine this patient? Yeah. Did you find that mass?
There was a vague lump around. A vague lump was palpable. It was non-tender.
No. You put exactly 5 centimeter mass. It is not vague. If you can measure and tell that it is 5 centimeter hard and not moving with respiration, that means it is not vague.
Yes, measurement should not have been mentioned. It was a vague lump.
Yeah, that is what I wanted.
It was
to
a
know.
vague lump. Yes.
Because the imaging shows hardly 5 centimeter mass.
Yes, very small lump. Yes.
And I have never come across that 5 centimeter pancreatic mass being palpated and
No,
so
it
much
was just a vague lump.
so
was
much
palpable.
so imagine
Overall,
if a pancreatic mass is to be palpated clinically, it's really very advanced.
Yes,
it's really very advanced in my experience.
the patient was also his BMI was 16. He was very thin built.
Maybe
that is one reason. But otherwise, although there was the dimension should not have been mentioned, it was a vague lump. Overall, it was unremarkable. Mostly a vague lump.
And since a mass is there, why didn't you consider malignancy in the first itself?
We had done markers. We had done markers of the patient. They had all come negative. CEA and CA99 had come negative. The total bilirubin of the patient was also just 7/4, and he was not in cholangitis, and more tapering of the distal CBD. We had a discussion with the CT because we always discuss our CT scans before surgeries. So patient was pramiphophase. We had a discussion, and they reported consistently that the patient had no lesion as such. Retrospectively, if we want to go, we would have gone for a perfusion scan or a MRCP to confirm. Also, there are multiple calcifications which were present throughout the pancreas might have obscured the other findings, and along with that, the smooth tapering was a little
what else you could have done
misleading.
Instead of MRCP?
We also could have done a US guided biopsy, FNSC or biopsy, but since preoperative was completely a misleading situation, so we could not go for.
No, calcification has nothing to do with this. It is a chronic calcification because of the pancreatitis, and it can have coexistent malignancy. But to throw the light, EUS would have been a better.
Would have been a better option, definitely, sir.
Manish, put that slide where you wrote exploratory laparoscopy.
Yes.
What exploratory laparotomy, apart from trauma, I don't think can be used, because in trauma you don't diagnose everything before you do a laparotomy.
Yes.
But with this modern imaging up to the molecules you are able to see, is there, you can call it
Staging laparotomy. Yes, so we should have followed. Yes, ma'am. I would take that. Staging laparotomy.
The point here, you preoperative, you had a confusion between the mass. Definitely, your points to say that the markers were right. Still in poorly differentiated pancreatic malignancy or the early pancreatic cancers, you might not be having an increase in markers and also Lewis antigen people also, then negative people also you might not have. But the point here I want to make is, have you got a consent for total pancreatectomy or is it an intraoperative decision? Because as I understand, you went into going for a phase, you found that tumors, you sent that because total pancreatectomy is a highly morbid and mortality procedure. One, they need to have a lifelong treatment for diabetic. Have you all explained with that, or the chances that if it were explained, then you would have closed it, then you would have gone back, explained to them, and then you would have come back. Yes, I understand that you go for the phase procedure. Yeah, you might have explained about Whipple's, where the Whipple's is different fit from total pancreatectomy. So that's
we had explained about Whipple's, but total pancreatectomy.
So that is totally a different set of complications and set of things that you might have to explain to them. Why did you go for total pancreatectomy?
Because of the multifocality of the lesions which we could palpate, and also the aspirate from the pancreatic duct was mucinous. It was from the body part.
No, it looks like there has been adenocarcinoma that was originating from the head and the body, possibly from the previous pancreas who had a chronic pancreatitis. So definitely your pancreas would be feeling the same way. Even in histopathology, the tumor was found only in the head and body. If you had found any other lesions, you would have taken a biopsy from the tail and you would have sent intraoperative frozen section, particularly if it is available in your setup.
The reason why we did not open, because we did not wanted to, in case of a malignancy, we did not want to cause seeding. So we just aspirated the fluid, which was mucinous. So
that's a possibility of the originated from IPMN. So the clinical scenario would have been, but in histopathology, it came out. It did not turn out to be IPMN along with malignancy. It was only the malignancy in the head and body.
With mucinous and squamous.
Thank you. Next presenter will be Girishant on the topic of rare case of post-traumatic testicular dislocation.
Good evening, everyone. I am Dr. Girishant, second year postgraduate from Department of General Surgery, SWIMS, Tirupati. I am here to present a case of post-traumatic dislocation of the testicle following RTA. Traumatic dislocation of the testicle is defined as the displacement of one or both testicles to a position other than the scrotum. It is a very rare clinical presentation of blunt scrotal injury that may take place in the RTAs. This can be easily missed due to presence of other severe accompanying injuries. So if missed, it can lead to infertility or malignancies. So this is a case report of a 17-year male presented with the complaints of swelling and pain in the right groin following RTA. On examination, the right hemiscrotum was empty and a swelling of size 4 × 2 cm was noted in right inguinal region. The well-defined borders, mobile, firm in consistency and smooth in surface. There is no local rise in temperature and mild tenderness was noted. So left hemiscrotum and the contents were normal. So on ultrasound, the right testis was seen in right inguinal region with a preserved vascularity. And a CCT abdomen was done. Showed a oval-shaped isodensity in a right inguinal region with plus 28 Hounsfield units in a pain study and plus 35 Hounsfield units in a contrast study, measuring 4 × 1.8 cm, suggestive of testis. So the right scrotal sac was empty. So surgical intervention done was emergency right inguinal exploration with orchidopexy was done. So the testis was noted in intraoperatively. Testis was noted in right inguinal region between scarpa's fascia and aponeurosis of external oblique muscle with preserved vascularity. The follow-up was done after 3 months and no complications were noted. So testicular dislocation is usually not fatal, but complications such as pain, malignant change, infertility, abscess or necrosis can occur if left untreated. So contrast enhanced CCT scan is useful in diagnosis of testicular dislocation. Surgery should be performed immediately in traumatic dislocation of testis when manual reduction was when manual reduction fails.
Krishan, when was this testicular translocation found out? With the primary survey or secondary survey?
Primary survey only.
That means you're wasting your time. Primary survey is to pick up immediate life-threatening injuries. Even if you picked up, you must put it in the documentation in the secondary survey. You got my point. The means your focus was not towards saving life. You can pick up. Nobody says no. But when you document it, should go into the secondary survey.
Yes, ma'am. But patient when he was presenting, no, ma'am, his vitals were stable. Ma'am. He was hemodynamically stable, and he was.
Whatever, this will go into secondary survey. In the documentation, in secondary survey, you found this. That is important.
Yes, ma'am.
You can be jumping around with the best PP. That is not the issue. This should go in the second. That's why I asked you. Was it primary survey or secondary survey? You thought, no, if I miss in the primary survey, man will catch me. No. You could have picked it up. Nobody is going to stop you from picking up peripheral issues in the primary survey. But when it comes to documentation, it should go into the secondary survey.
Yes,
Number two. Number two, why did you do a CCT?
Ma'am, to rule out other solid organ injuries in abdomen.
Very good. Because force was quite a bit to push the testis up.
Yes, ma'am.
So your CCT was not to look at the testis.
Yes, ma'am.
It was to look for other injuries in the abdomen. Fair.
First slide, please. First slide. Yeah, next. Oh, no. What were the other injuries actually for what patient came to you? What were the, whether there was any significant other injuries, or he told only there is a scrotal pain or something?
So patient, he came with complaints of swelling and pain only, sir, in right groin region. Following RTA, that's all, sir. Patient was hemodynamically stable. No other complaints were there, sir. No other injuries were also not there, sir. No external injuries were also there, sir.
So, can you imagine such a situation where there is no other injury and the scrotum is having an impact to dislocate the testis?
In retractile testis.
Yeah, that's what I want to tell. Whether this is solely due to the trauma or not itself is a question here.
Yes, sir.
Whether it's solely due, because there is no other injury whatsoever. We have seen lot of testicular injuries, can present with hematoma, etc. No injury, no external impact, and nothing is there, and the force is thus such a big to dislocate it to the groin. Doubtful.
So cremastic reflex was not that.
No. That's why you must tell mechanism of injury. What exactly happened?
What was the mechanism of injury? What was the impact?
Sir, while he was traveling on a motorcycle, he suddenly brake. Yes, sir.
Okay.
Yes.
So probably it is a sudden contraction of the muscle and causing the retractile testis rather than the dislocation of the testis as such.
So, but manual in retractile testis, when cremastic reflex is decreased, the testis can be positioned back to scrotum, sir. But here it was not. I mean, under sedation we tried for our manual reduction, man. So, but it was not reduced.
Was it done under spinal or general anesthesia later?
Later, spinal, ma'am.
Okay. Did you give some time to see whether the testis comes down? That is an observation which should you make.
Yes.
Under anesthesia, whether the testis is going back into the scrotum. An observation should be made and written also.
Yes, ma'am.
That is important. Like the way you palpate for an appendicular lump, no?
Yes,
before you take up a late appendicitis, that recording must be done. And your RTA, when you find the injuries not answering your questions, you need to go more into the mechanism of injury.
Okay.
Not just two-wheeler. Two-wheeler could have crashed against a bus. The amount of momentum transfer would be much more than him just braking. You got my point. That's why you have to go more into the mechanism of injury.
Yes, ma'am.
Can any other injury cause like this? You said RTA ending. What other types of injuries can cause? So he's a 17-year-old boy.
Sir, any injuries, blunt injuries to scrotum can cause.
That was the last presentation. Thank you judges for your valuable time. Thank you, Chairperson, for your valuable time and for the judging faculty. Next, we move on to the oral paper presentation. Our judging faculty for our next session will be Professor Dr. Uday Shambakumbar, Professor Dr. Nandakeshwar Moraju, Dr. Suresh Kumar, Dr. Balamurugan. I request everyone to occupy their seats. Instruction to the participants to kindly adhere to the time of 7 plus 3 minutes, 7 minutes of presentation and 3 minutes of discussion. Our first presenter will be Dr. Gopi Krishna on the topic of effective timing of intralesional clip placement on surgical outcomes in patients undergoing breast conservative surgery post MACT.
This is to change the slide. I just want to change. No, that will come. That will come. You wait. I have to start the timer. There's no
Please start.
Okay. Good afternoon, everyone. Myself, Dr. Gopi Krishna, final year junior resident, Department of Surgery from the JIPMER. Today, my poster presentation is on effect of timing of intralesional clip placement on surgical outcomes in patient undergoing breast conservation surgery in a setting of post MACT setting. It was a pilot study. We all know breast cancer is the most common malignancy in the world and in India also, with estimated 2.3 million new cases in the year of 2020. In the olden days, modified radical mastectomy is a surgical treatment of choice for patients who are like locally advanced breast cancer. Since the discovery of neoadjuvant chemotherapy, it will downsize and downstage the locally advanced breast cancer, and it will convert the patient eligible for breast conservation surgery also. To performing a breast conservation surgery in a locally advanced breast cancer patient, we need to localize the tumor bed. It is very mandatory. Various studies have proven like radio-opaque marker clip have found to be cheaper and effective for the tumor localization. However, the timing of the clip placement is still debated. Our primary objective to look for radiological and pathological clip migration with respect to timing of the clip placement. And our secondary objective to look for specimen value and then re-excision rate with respect to timing of the clip placement. Our study participants were divided into two groups. In group A, patient who underwent upfront clip placement before initiating the chemotherapy. And in the participant in the group B, they received 2 cycles of chemo. After that clip placement, after they completed further cycles of chemotherapy. Our study was open label single standard pilot study. It was conducted in the JIPMER only between the time period July 2022 December 2023. Breast cancer patient who is having stage 1, 2, 3 and who is planned for neoadjuvant chemotherapy, who is above 18 years of old, they were included in the study. Exclusion criteria for our study was like patient who were to refuse to participate in the study and the general contraindication to breast cancer missing surgery, like multicentric tumor and the larger tumor to breast ratio, and then patient who is having contraindications to radiotherapy like systemic SLE and systemic sclerosis and all. This is a console diagram. Initially, at the enrollment point, totally 54 patients assessed for eligibility. Because of the various reasons, 9 participants were excluded. Using the computer-based block randomization, 45 participants were allocated into 2 groups. For allocation, concealment, we used opaque sealed envelope method. And group A patients, they received upfront clip placement, and group B patients received clip placement after 2 cycles of neoadjuvant chemotherapy. After the clip placement, both the group patients has received 6 to 7 cycles of neoadjuvant chemotherapy as advised by the medical oncology department. At analysis, 17 participants in the group A and 16 participants in the group B as underwent BCS, they were analyzed. Okay. For clip placement, we used commercial marker clip, the ultra clip dual trigger marker clip. It is made up of titanium. It's a single disposable clip. Okay. Under ultrasound guidance, single clip was placed at the center of the tumor by the radiologist. After clip placement, post-procedural mammogram was taken. First picture depicting the craniocaudal view, and the second picture depicting the medial oblique view. After completion of the chemotherapy, the repeat mammogram was taken preoperatively to look for any clip migration. Solo mammogram was taken to look for clip position, to look for any clip migration is present or not, and to plan for any tumor bed localization like wire guide localization or CT guide localization. After the completion of the NACT, the patient attained the various response. The patient who overall partial response, palpation guided lumpectomy was performed. Patient who achieved complete response, it is necessary to localize the tumor bed. Further, we used wire guide localization or ultrasound. The tumor, the residual tumor with the clip with unsymmetrical margin, we excised and we sent for histopathological examination. During intraoperative itself, to promote the margin status, intraoperative fluorescence exam we performed. After the BCS surgery, to confirm the clip retrieval, we have taken specimen mammogram to look for the clip position in that specimen also. The clip migration by definition is like the displacement of marked clip 1 centimeter from the tumor margin. A specimen volume calculation was our secondary objective. For that, we used the formula, which is like D3 pi divided by 6. This is based on the previous studies. And we used per protocol analysis for our statistics. Since our study was pilot study, we have taken only 30 participants, and the analysis was performed using SPSS version 19.0 software, and categorical variables were expressed as frequency and percentage, and the continuous variables were expressed as mean and median. And the Kolmogorov spin of test was used to assess the normality of the study. The continuous variables were compared between the groups using the independent t-test or non-Whitney test based on the normality of the study, and the categorical variables calculated using chi-square test. P-value less than 0.05 are considered to be significant, statistically speaking. Coming to results, while considering the demographic characteristics of the patient, like age and menopausal status and BMI were comparable between each group.
Take us to the key points and conclude.
Okay. And hormonal status and tumor stage found to be like comparable between each group and equally distributed also. There were no statistical significance was there. And our primary objective is to look for radiological clip migration. Patient who had a residual tumor at the end of the NACT, actually in group A and group B, the both groups, 3 patients achieved radiological complete response. Like 14 participants in group A and 13 participants in group B had residual tumor. In those two residual tumor, we looked for clip migration. One participant in the group A had radiological clip migration, which was found to be non-significant, statistically non-significant. In the post-operative histopathological specimen, patient whoever had residual tumor, like group A had 7 patients, group A had residual tumor, 11 participants in the group B had residual tumor. In those we looked for pathological clip migration. Out of those, in the group B participants, out of 11 patients, 1 patient only found to have pathological clip migration, which is also non-significant. And specimen value also calculated. We used median because it was not followed the normality, which is also not found to be significant. On conclusion, when the patient breast cancer patient is planned for breast conservation surgery followed by following the NACT, to assess the surgical outcomes like clip migration or specimen volume or re-excision rates, irrespective of the timing of the clip placement, the surgical outcome will not be different. There will not be any statistically significant difference we can expect in our study based on our study. So we can place either upfront also, we can place clip after 2 cycles of chemotherapy also.
So I'll just take the question. You said your primary outcome was clip migration.
Yes, sir.
So did you calculate your sample size keeping this in mind because you had some complete tumor response? Isn't it? You had a tumor response also there, full complete tumor response was there.
Yes, sir. Yes, sir.
Right. So you don't have any tumor margin to compare the clip to.
Yes, sir.
Isn't it?
Yes, sir.
So finally, the sample that you had was only those who had a tumor present.
Yes, sir. We calculated based.
So did you use that as the determinant for your sample size calculation?
No, sir. Like we not consider that the complete response and all. The entire whole participant we consider initially. That's why we took the small response.
That's why your results may not be very reliable.
That might be one of the.
You have had any other determinants of this? Doesn't matter.
Okay.
Yours is a randomized trial, right?
Yes, sir.
Okay, so you put only pilot study. Even if it is pilot study, you're supposed to mention that pilot randomized pilot study.
Okay, sir.
And you use block randomization.
Yes, sir. Block randomization.
How the patient had one group 24 and another group 21. What blocks you used?
Sir, the sequence of sir random levels of tables, sir.
No, you said block randomization.
Block randomization.
So no, if it is block randomization, it has to be blocks of something.
Tables.
No, blocks of 2 or blocks of
yes,
4, 6. Like
3, 4 we used to, sir.
Huh?
3 to 4.
Uses only 2 arms. Why you use 3, 4? And you can't use 3 and 4. It has to be either, if it is 2 arms, it has to be 4, 6, 8 like that. If it is 3 arms, then 3, 6 like that. Okay.
Why it is open label? Why blinding is not involved? Any reason?
So anyway, like patient also will know, like they received already 2 cycles of chemo, and then we are going to place the clip, and the patient also will be know, like and then the investigator also like must be knowing only, sir. Like it will be like open label only.
Okay, and why after two cycles of chemotherapy?
Actually, one theory was there, sir. Like during the chemotherapy response, according to the tumor shrinkage pattern, some participants will respond like concentric shrinkage. In some other people will respond like non-concentric shrinkage. Like in one part of the tumor alone it will shrink, other part of the tumor will remain intact. That was the theory what proposed for clip migration. Okay, that's why after giving 1 or 2 cycles, we delimit the tumor margins. Then after that, we'll place the clip at the center of the tumor. That is one theory. Like to prevent the clip migration, previous. Yes, sir. Thank you, sir.
Thank you. Next. 1 second. Please ensure you stop your presentation at around 7 minutes because your question time is part of the 10 minutes.
Next participant will be Pavitra. Since she's not there, we move on to the next participant, Dr. Surya, on the topic of skin closure parathyroid hormone as a predictor of transient hypoparathyroidism after total thyroidectomy.
Good evening, sirs. Myself, Dr. Surya, junior resident in the Department of Surgery. My topic is skin closure parathyroid hormone as a predictor of transient hypoparathyroidism after total thyroidectomy. It was a prospective analytical study. Introduction. Postoperative hypoparathyroidism remains one of the most common complications that occurs after total thyroidectomies, and most cases are transient and they're asymptomatic. However, permanent hypocalcemia, which is usually represented if it's persisting for more than 6 months, can be debilitating in terms of lifetime dependency of calcium supplements, which cause significant loss in the quality of life. The incidence of transient hypoparathyroidism varies between 19 and 38%, whereas permanent hypoparathyroidism can be up to 3%. Many studies have shown that early PTH assays taken at any time from 10 minutes to several hours after surgery has shown to have value in predicting the patients who are at risk for hypocalcemia. Early PTH levels can also affect postoperative management and helps eligibility for early discharge. So the primary objective of this study was to study the predictive value of parathyroid hormone taken at skin closure in identifying the occurrence of transient hypoparathyroidism in patients undergoing total thyroidectomy. And my secondary objectives were to analyze the risk factors involved in the occurrence as well as to assess the vitamin D levels in patients with transient hypoparathyroidism. So it was a single center prospective analytical study. All patients who are more than or equal to 18 years of age who underwent total thyroidectomy for a benign or a malignant cause presenting to surgery and ENT department in JIPMER between January 2022 and January 2024 were included. Patients who had coexisting parathyroid pathology or patients with chronic renal impairment, patients who are already on oral calcium or vitamin D supplements, and patients undergoing bilateral neck dissection were excluded from the study. Anticipating the diagnostic ability of early PTH assays in predicting transient hypothyroidism with area under the curve of 0.8 based on previous studies with 5% level of significance and 90% power, the initial sample size was calculated to be 39 and with a 10% attrition rate, the final sample size was estimated as 43. The diagnostic accuracy of early PTH assays was assessed using receiver operating characteristic curve which measured the sensitivity, specificity, and accurate cutoff value with a 95% confidence interval, and p-value was considered significant if it was less than 0.05. So this was a study procedure. Patients more than 18 years satisfying the inclusion and exclusion criteria were included. Preoperative biochemical tests including calcium, albumin, PTH, vitamin D were taken, and routinely all underwent total thyroidectomy without neck dissection. And intraoperatively, details of the surgery like length of incision, identification of parathyroid glands, parathyroid autotransplantation, the duration of surgery were all recorded. And after removal of the thyroid specimen within 10 minutes before the skin closure, PTH samples were taken using a pre-chilled EDTA tubes and they were assessed immediately. And postoperative and postoperative zero serum calcium levels were taken. Patients were observed postoperatively for the signs and symptoms of hypocalcemia. And following up, IPTH as well as calcium were taken on postoperative 2 and 14. So the results, a total of 43 patients including 12 men and 31 women who underwent total thyroidectomy were included. All patients were normocalcemic preoperatively. Among them, 27 patients, that is 62.79%, developed transient hypoparathyroidism. And all demographic and biochemical characteristics were comparable between the two hypocalcemic and as well as the normocalcemic groups. So the main objective comparing the skin closure PTH levels between the two groups, patients who had PTH levels less than or equal to 10, keeping this cutoff, 15 patients, that is 100% of them who had a cutoff less than 10 PTH developed hypocalcemia and the p-value was significant less than 0.001. And comparing the risk factors associated between the two groups, the etiology for the surgery, that is the malignant groups, had higher incidence of hypoparathyroidism, with 75% developing hypocalcemia in the malignant groups, and only 40% developing hypocalcemia in the non-malignant groups. And the other risk factor based on the number of parathyroids that is identified during surgery. If all parathyroids are identified during surgery, there are only 42.31% incidence of hypocalcemia. And if there were less than 4 parathyroids identified during surgery, the hypocalcemia rates were high, which was around 94.12%, which also had a significant p-value of less than 0.05. And on comparing the secondary objective, that is the vitamin D levels in patients with this hypocalcemia, there was no statistically significant difference found with both the groups. And it was also noted that only 3 out of 43 patients had vitamin D deficiency, and in which 2 out of these 3 patients who had hypovitaminosis developed the hypoparathyroidism. On comparing the length of hospital stay, it was noted that most patients who did not develop hypocalcemia and who were detected early had less hospital stay. So this was the receiver operating characteristic curve for IPTH sampling, and the IPTH levels with the hypocalcemic levels were charted, and the area under the characteristic curve was found to be 0.62. And comparing the sensitivity, specificity, and predictive ability based on this ROC curve at the skin closure IPTH level, the best cutoff with the higher sensitivity and specificity around 90% was found with a cutoff of 13.25, and the area under the curve was found to be 0.7. So discussion, numerous studies have showed that PTH can be used as a reliable indicator for identifying this transient hypoparathyroidism with varying cutoff as well as varying time period. In our study, by keeping a cutoff of less than 10, we found that the sensitivity and the specificity was found to be 31% and 59%. Actually, when we took the IPTH levels that was done at 48 hours, in our study was found to show a higher sensitivity and specificity. But this could be due to, we do not recommend doing a PTH assays as 48 hours because since due to shorter half-life of IPTH of 3 to 5 minutes, it is noted that if there is any damage to the parathyroid glands, the PTH levels can drastically fall during the first 48 hours itself. So if we do assay at after 48 hours, we could have missed the patients who develop hypocalcemia in the initial 48 hours period. So conclusion, based on this study, we conclude that doing IPTH at the time of skin closure can predict the occurrence of transient hypoparathyroidism, and total thyroid malignancy as well as the number of parathyroid glands that are identified intraoperatively were found to be independent risk factors in predicting the occurrence. And due to small sample size, the role of vitamin D we are not able to accurately predict, and further studies with larger sample size are required to prove this.
Why you wanted to see only for a transient hypoparathyroidism? It can be applied also for the permanent hypoparathyroidism as well, no?
Yes, sir. Many studies are there to identify permanent hypoparathyroidism, which is lasting for more than 6 months. There are fewer studies which have showed the effect of intraoperative PTH levels to predict the transient. Usually, when IPTH is low, it means that the parathyroid glands are damaged, and most of them will result in permanent hypoparathyroidism. So, there are various studies which have showed the occurrence of permanent, but transient hypoparathyroidism, the number of studies which has assessed the role of skin closure PTH is less. Okay. So that is why we wanted to do.
Okay, what is the clinical implication of this study?
The clinical implication is that instead of doing multiple serum calcium levels in the postoperative period to find hypocalcemia, like usually we find after developing the symptoms. So using a single PTH levels that is done at intraoperatively can be used to.
No, is it possible to manage the patient with only IPTH level without calcium levels?
We need calcium levels also, sir, but instead of repeated sampling with the calcium levels, so this study is not, it's mainly to analyze the patients beforehand, that is intraoperatively, and to start early calcium supplements so that we avoid the symptoms of hypocalcemia.
Why did you choose this? Because you said hypoparathyroidism from 10 minutes till so many days. Why did you choose that skin closure? Why? What is the significance? Why not like, because what is the time between your specimen extraction closure
So
why did you
considering the
choose that as-
half-life of PTH is about only 3 to 5 minutes, it is noted that the fall in the PTH, if there is any damage to the glands, occurs immediately. So that is why 10 minutes after removing the thyroid gland, after completing the surgery, we wanted to look.
So that can be done even at extubation time or something like that. But why did you keep at skin pressure? Is there any rationale behind that?
Just for uniformity.
And your primary thing is objectives about hypoparathyroidism. So, which is clinically you are taking or only serum calcium? Based on which level you are saying this is hypoparathyroidism?
Sir, I have included transient hypoparathyroidism based on whether patients having serum calcium levels less than 8.5 or PTH cutoff less than or equal to 10 and patients having signs and symptoms of hypocalcemia. All these three parameters I have included to define as transient hypoparathyroidism.
Is it to all of the three or
Any one of the three.
The same again, I'm going to ask, like, what's the clinical significance? The patient is going to develop a transient hypothyroidism. We are going to supplement it by identifying it as the risk factors and how we are it's going to help the patient. We're going to predict the patient who's likely to develop a transient hypoparathyroidism. Right?
So the thing is, most of the patients calcium levels tend to fall late, sir. Sometimes we discharge patients on post-op day 2, that is after 48 hours we discharge, and patients come back with this with hypocalcemia. So if that is the case, we can miss the diagnosis of early hypocalcemia diagnosis. So by doing PTH, we can identify if the patient is prone to develop hypocalcemia even after 48 or 72 hours.
Now you have repeated the calcium on 48 hours and 14 days.
14 days, sir.
Okay, thank you.
So as disclosure, I'm a co-author, so I won't be scoring her. Thank you.
Thank you, sir.
Thank you. Next presenter will be Dr. Rajalakshmi on the topic of levofloxacin-based therapy versus hybrid therapy in the eradication of Helicobacter pylori.
Good evening, everyone. I'm Dr. Rajalakshmi, final year junior resident from the Department of Surgery, and today I'll be presenting my thesis titled Levoflox-based therapy versus hybrid therapy in the eradication of Helicobacter pylori. It's a randomized control trial. So, International Agency for Research on Cancer categorized H. pylori as a Group 1 carcinogen in 1994. Being a developing country, the prevalence of H. pylori in India is very high. It's around 80 to 90%, and it's been proven that elimination of the disease reduces the risk of gastritis and thereby gastric cancer. For the past many decades, standard triple therapy was the regimen of choice for eradication of H. pylori, but in the past few years, the eradication rates have dropped drastically from 90 to an unacceptable 60%, and this has mainly been attributed to antibiotic resistance. So, in view of this, in the past few years, many new regimens have been put forth. One of them is called hybrid therapy. It's also called dual quadruple therapy. It consists of a proton pump inhibitor and amoxicillin for 14 days with the addition of clarithromycin and metronidazole in the later 7 days. Hybrid therapy is widely used in private sector, and but it has its own problems such as being a complex regimen, and also it contains clarithromycin, for which again resistance is on the rise. So we thought of something which could be used as a simpler alternative. That's when we came across Levoflox. Levoflox is an established rescue agent which has very good eradication rates, as good as a first-line agent. Also, it's a simple triple regimen, and at least till now, resistance is uncommon. So keeping all this in mind, aim of our study, primary objective of our study was to compare the efficacy of eradication of H. pylori between Levoflox-based therapy with hybrid therapy in patients with apogee disease requiring eradication. Secondary objectives were to compare the compliance and adverse effects of both regimens. This was a single-center, prospective, open-label, parallel, non-inferiority RCT, and participants were all patients more than 18 years of age who presented with symptoms of dyspepsia, underwent apogeoscopy, and tested positive for H. pylori. Exclusion criteria is previous eradication therapy, intake of antibiotic therapy in the last 4 weeks, past history of gastrectomy, any major comorbidities, other malignancies, or portal gastropathy. Sample size based on previous studies was calculated to be 134, that is 67 in each arm, keeping a non-inferiority margin of 10% and an expected dropout rate of 10%. So this is an overall schema of the study. Patients who came with apogee symptoms who underwent apogeoscopy and tested positive for H. pylori after applying the exclusion criteria were randomized using block randomization into either Levoflox-based arm or hybrid arm. And both of them received therapy for 14 days each. 6 weeks after the end of the therapy, they were followed up, and patients who had ulcer disease, patients who had ulcer disease, repeat upper GI scopy was done, and non-ulcer disease patients, rapid stool antigen test was done. Along with this, during the follow-up visit, side effects and complaints were also measured. So these are the two regimens, as I already mentioned. Levoflox is a triple regimen with mox, levoflox, and omeprazole given for 40 days. Hybrid therapy had moxilin, omeprazole for the initial 7 days, with the addition of clarithromycin and metronidazole for the next 7 days. Statistics, there were two kinds of variables, continuous and categorical. Continuous variables were analyzed using unpaired t-test, and for categorical variables, chi-square test or Fisher's exact test was used. This is the consort chart. Initially, we enrolled at around 187 patients, after which finally 134 patients were included in the study after applying the exclusion criteria. 67 were allotted into each arm. Initially, intention to treat analysis was done. Afterwards, patients who were non-compliant were excluded, and a modified ITT analysis was done. Afterwards, patients who were lost to follow-up were also excluded, and a protocol analysis was done. Moving on to results. The first table shows a comparison of baseline characters of the patients in both the arms. We can see that all the p-values are non-significant, indicating that both the groups were comparable in terms of age, sex, and risk factors. Table 2 shows a comparison of eradication rates between both the groups with ITT analysis. So, table 3 is a similar table with modified intention to treat analysis. We can see that numbers are almost the same in terms of eradication, indicating that both levoflox and hybrid therapy had similar eradication rates. Table 4 shows again comparison of the eradication rates between both the groups using per protocol analysis. Again, both eradication rates were found to be similar. Graph is a compilation of the previous tables. You can see that initial two blocks show LBT and hybrid with ITT analysis. Second two blocks show MITT, and the next show per protocol analysis. As we can see, there is a sequential increase in the eradication rates as expected, except in the MITT arm. This we thought could be, this is the only discrepancy in the result. We thought some of the patients who were actually non-compliant could have gotten eradicated by chance. So that is why there's a dip in the graph. Otherwise, results are as expected. Table 5 shows a comparison of compliance between both the groups. Here again, compliance also, even though the numbers are slightly different, complaints are similar. And again, this graph shows side effects, except for arthralgia, which is a known side effect of levofloxacin. Rest of the side effects are also found to be similar between both the groups. So this is the final table, which is again a compilation of the results. Shows that all levoflox and hybrid therapy groups, both in all the three analyses, were found to have similar eradication rates, indicating that levoflox has eradication rates non-inferior to hybrid therapy. Strengths of the study are that this is a randomized control trial with fairly large sample size, and this is one of the few studies comparing LBT and hybrid therapy. Limitations are that antibiotic susceptibility. Antibiotic susceptibility testing could not be done due to logistic reasons, and also cost analysis could not be done as is a public sector study. So in conclusion, eradication rates of H. pylori, complaints and side effects in LBT and hybrid therapy was comparable, and the former can be used as a simpler alternative to hybrid. Thank you.
Co-author for this paper, I'm declaring conflict of interest, and I'm not marking.
So, how did you look for compliance? Because in one arm you had 4 tablets to be taken, the other one had, or it's 3 only?
4, sir. Actually,
4. So how did you look for compliance?
3 tablets, sir. The second one had 4
much
tablets.
later, yeah.
80% of the tablets, if they had taken, more than 80% of the tablets.
Is it self-reported or you inspected their blister packs?
Told them to bring the.
So did you personally verify,
yes,
or
yes, sir,
it's
yes,
reported?
For the second one, actually, there were initially 2 drugs and then later 4 drugs. So in either of the first or second, like at the first 7 days or the second 7 days, 80% of the drugs, if they had taken more than 80%, we kept it as compliant.
Okay. I'm surprised to see that your altered taste and nausea were more in the levofloxacin group and not the metronidazole group. I would expect metronidazole to have greater amount of altered taste. Is it that you are probing more closely this group? Was there an observation bias? Because you would expect the hybrid therapy to have more incidence of altered taste and nausea.
Yes, sir.
Yeah. Then cost analysis, how does it matter if it's in a public hospital? Why could you not do a cost analysis? You know the cost of the drugs. It's just difference in drugs. No, you could have done a cost analysis.
Like all the drugs here was available. I mean, if it was,
but you will know
if
an
we
index cost of the drug. No, it is not so difficult to. It's not an intangible.
Here we could have done. Sir, I meant if we extrapolate the same data to a public sector, it would be private sector.
Why you chosen the non-inferiority design?
Sir, hybrid therapy is already an established, like proven, not the gold standard, but it is an established regimen. So to add a new regimen, it is enough to prove that it is non-inferior to the existing regimen. There is no need to prove that there is superiority. That is one thing. One more is we like even if it is non-inferior, there would be advantages in terms of other things, like there are lesser number of drugs, so we expect a better compliance, and also adverse events also we expect it to be lesser, even though it is not statistically significant. So there are other advantages.
How you calculated the sample size? What was the non-inferiority margin you have taken? You have not mentioned anywhere.
Sample size was calculated based on previous studies. Like as rescue agent, levoflox had eradication rates of around 90 to 92. As a rescue agent, previous studies have shown that levoflox had eradication rates of around 90 to 92, and hybrid therapy also similar in the ranges of 90. So based on that, keeping non-inferiority of 10.
10%. Okay, fine.
Now, for non-ulcer disease, you used stool antigen.
Yes.
And for ulcer disease, you did rapid urease, right?
Ulcer disease,
You did a repeat for eradication.
urease.
So what is the detection rates of these two?
Stool antigen test has a sensitivity of around sensitivity specificity both around 96 to 97, sir.
Okay.
Not as good as apergioscopy, but
So will that skew the result? Like how many patients were there in ulcer disease? Because you are just comparing as a whole, right?
ulcer disease patients were very few, so 4 or 5, and also it won't be for uniformity. It won't be ethical to do a repeat scopy in non-ulcer patients. Also,
So you could have done stool antigen on for all the patients, including ulcer disease, at least for the study purpose. Though you could have done an endoscopy, but not use rapid urease for them, but use stool antigen for them also. If it is just few numbers, that would have been a better thing. Yeah.
Our next presenter will be Dr. Jnaneshwar Manivandan on the topic of incidence, predictive factors, and post-operative outcomes of patients undergoing pancreatic duodenectomy for non-pancreatic periampullary cancer with para-aortic lymph node metastasis, a prospective and a retrospective study. Our next presenter will be Dr. Lakshmi Sriram.
Good afternoon, everyone. I'm Lakshmi Sriram, Junior Resident in Department of Surgery, JIPMER, and I'm here to present a study, the comparison of incidence of abdominal wound dehiscence in Hughes abdominal wall closure technique with conventional interrupted abdominal closure technique in emergency laparotomy. It was a randomized control trial. As we all know, facial dehiscence is a major complication of both elective and emergency abdominal surgeries, with rates of burst abdomen ranging from about 1 to 3% in open elective surgeries and up to 50% in emergency surgeries, including damage control or trauma-related surgeries. And burst abdomen is associated with an increase in mortality rates, ICU admission, overall hospital stay, as well as healthcare costs, and is noted to be associated with a decreased quality of life. However, despite multiple studies and large-scale randomized control trials as well as multiple systematic reviews, there has been no established consensus as to any specific suturing technique or suture material which is proven superior to another in decreasing the incidence of burst abdomen following a laparotomy. Now, Hughes abdominal wall closure technique was initially described by Leslie Ernest Hughes, and it is a combination of horizontal and vertical mattress sutures in a single suture, which is noted to distribute the tension across a wound during closure along the line of incision. And it is a relatively novel technique which has previously been established for laparostomia closures or repair of small incisional hernias. There have been small-scale studies regarding its role in decreasing the incidence of wound dehiscence. However, large-scale RCTs are lacking. Now, the primary objectives of this study were to compare the incidence of abdominal facial dehiscence in Hughes abdominal closure technique with conventional interrupted closure following an emergency midline laparotomy. And the secondary objectives were to compare mortality at 3 months, quality of life at 1 month, and incidence of incisional hernia at 1 year following the surgery among the two groups. Now, it was a single center open label randomized control trial with the two groups being group 1 being the conventional interrupted closure technique and group 2 being the patients undergoing Hughes closure technique. The inclusion criteria included patients more than 18 years of age with a midline abdominal incision of more than 5 centimeters, and patients undergoing relaparotomy or those with a prior history of radiotherapy or those undergoing delayed closure, as well as those with a connective tissue disorder were excluded from the study. Now, the study procedure, emergency laparotomy was done as per the indication, and the randomization was done prior to abdomen closure, and it was stratified based on wound class, with the stratification being class 1 and 2, which involve clean and clean contaminated wounds, and 3 and 4 being contaminated dirty wounds. And then the patients were randomized into the two arms, with the patient in the conventional closure arm undergoing interrupted mass closure with 1 proline, with the bites being 1.5 centimeter apart, and the intervention arm undergoing Hughes closure, which involved a far bite starting 2 centimeter from the edge of the linea alba on one side, taken from outside in, then a near bite 0.5 centimeter from the facial edge on the other side, followed by a near bite on the same side, and then a far bite on the opposite side, and then a horizontal mattress of the same thing, 1 centimeter distal to the first one. This is an intraoperative image. Now, the outcome assessment was done. The patients were followed up during the hospital stay up to discharge, as well as at 1 month post-surgery. And post-operative morbidity data was recorded, and the total length of hospital stay, as well as any duration of ICU stay, as well as other post-operative complications were recorded. And throughout the hospital stay, they were monitored for facial dehiscence. In case of any focal dehiscence or discrepancy regarding whether or not facial dehiscence is present, the final decision was taken based on the opinion of the operating surgeon. Now, the statistical analysis, initial sample size estimation was done to be 220, which included 110 patients in each group, based on a small-scale study conducted in Nepal by Agarwal et al., who detected a difference in incidence of burst abdomen from 19 to 6%. The study was powered to 80% with an alpha error of 5%. And the results were expressed in terms of proportions with 95% confidence interval, and categorical variables were compared using chi-square test, and quantitative variables were compared using independent t-test or Mann-Whitney test. Now, out of a total of 231 patients who had presented to the JIPMER casualty, 174 patients were assessed for randomization. However, 6 were excluded during the surgery as primary facial closure was not done, and a total of 168 patients underwent randomization, and with 84 patients in each arm. However, in the immediate post-op period, a further of 16 patients were excluded as they underwent elective re-exploration, and a total of 77 patients in group 1 and 73 patients in group 2 underwent the modified intention to treat analysis. Subsequently, in view of high post-operative attrition due to early post-operative mortality, a worst case scenario analysis was done, recoding all early post-operative mortalities as having developed the primary outcome on the day of death. Now, the baseline parameters were noted comparable between the study groups except for gender, with a mild higher number of males in the intervention control group as compared to the intervention group. And surgery characteristics such as wound class, indication for surgery, post-op ICU admission, as well as duration of surgery and intraoperative blood loss were comparable. Primary outcomes, the incidence of burst abdomen overall was noted in 16% of the patient population, and there was no statistically significant difference noted between the control group as well as the intervention group. And secondary outcomes, mortality was compared at 1 month of all causes, and there was no statistically significant difference noted in this as well, even though there was a slightly lower absolute numbers in the intervention arm. Similarly, no statistically significant difference was noted between the groups in terms of incidence of surgical site infection, median duration for development of wound dehiscence or surgical site infection, and overall length of hospital stay. And independent factors which were identified as being associated with wound dehiscence included duration of surgery, presence of post-op surgical site infection, as well as ICU admission. Now, the worst case scenario analysis was also consistent with the primary modified intention to treat analysis, and the secondary objective initially planned was to compare mortality at 3 months. However, as the data set was incomplete, the test of significance was not applied for the 3-month data. Quality of life analysis could not be done due to logistic reasons, and 1-year follow-up is still pending. Now, in this study, as previously mentioned, no statistically significant difference could be detected between the two groups in terms of incidence of burst abdomen, and duration of surgery, surgical site infection, and post-operative ICU admission were noted to be independently risk factors. Now, mainly in view of the inadequate sample size, it is possible that this study was inadequately powered to detect a statistically significant difference, and further studies with higher sample size is required to confirm.
So this is a study where we don't have long-term follow-up, and your sample size also was low. So my question is, how did you standardize the sutures for the study group? Because it's a new technique, and if you're going to use that as an intervention, you have to standardize that. How did you standardize?
We had a preoperative video which was circulated to all the senior residents who were part of the study, and an explanation of how the procedure has to be done, as well as the video was provided for instructional purposes for standardizing the procedure.
No, but that is only training them what they have to do, but what they have done, did you standardize? The bites,
measurements were standardized. Intraoperative scale was used
for every patient.
Yes, sir.
Was used.
Yes, sir.
Okay. So my follow-up question is, did you also standardize the conventional closure?
The conventional closure was also standardized, with the bites being 1.5 centimeters from the facial edge, again with an intraoperative scale.
Did you study any biomechanical models to see what actually happens to tensions and pressures? This is in patients, no, but this is basically a suture holding two ends together. Did you at least refer or look at any biomechanical models? Was there studies on the tensions done for the same thing elsewhere, outside a patient?
For Hughes closure, I could not find any biomechanical models that were described. However, previously, multiple models have been used to describe the tensions across the suture line.
But for this one, there are no models?
Yes, no, sir.
again, the follow-up, like such questions only. How many surgeons were involved? Because there are too many surgeons, and obviously that it is a technical thing. So too many surgeons involved, there will be a lot of variations in their techniques. So how many surgeons were included? Is that all senior residents in the Department of Surgery, or any specific number?
All senior residents in
Then that again, too many, like 20 plus surgeons for nearly 84 patients is too many variations. That also could be possibly affecting. And your sample size, you said the difference, what you wanted to calculate is 19.6%. Right, it's a huge variation difference, nearly more than 10%. This is still the sample size you calculate is more, like 84 plus 84.
220 was the calculated sample size, sir, and attained sample size was 168, which had not attained.
That's what your observed difference you wanted to see is little huge, right? So the sample size is supposed to be little lesser when your effect size is so large. That's what I was asking. What is the total number of burst abdomen in your case?
25 patients.
25 patients. Can you go show that slide? It is exactly 50 in clean and clean contaminated, and contaminated dirty is 100 patients. What randomization is a simple randomization, or is a block randomization kind of?
It is a simple stratified randomization. Stratified based on one class, but no block randomization was done for the individual.
Okay, because it's absolute numbers, no? Like 50, 100 in a computer generated random without block size appears to be a little difficult to obtain. Okay.
Since I am a paid conflict of interest, I will not ask.
Why you chosen only the emergency laparotomies and not elective one?
Sir, since the two reasons. One, because study duration is limited and incidence of burst abdomen is quite low in elective surgeries. It would require a larger sample size as well as to establish any statistically significant difference. And secondly, in literature, a lot of data, there is a lot of data describing huge closure in elective surgeries. However, emergencies, in the emergency setting, there is not much literature which describes the role of this technique. So.
Good evening to one and all present here. I'm Dr. Jnaneshwar, Junior Resident Department of General Surgery from JIPMER. I'd like to thank my guide, Dr. Rajkumar sir, and my co-guide, Kalayarsan sir. Pancreaticoduodenectomy, or commonly known as Whipple's procedure, is the treatment of choice for resectable periampullary cancer. Para-aortic lymph node involvement in pancreatic cancer is considered metastatic according to the Japanese Society for Pancreatic Cancer, but not in the latest edition of AGCC 8th staging. Since then, several studies have advocated routine frozen sections of para-aortic lymph nodes before pancreaticoduodenectomy, as it correlates with poor survival in patients with positive para-aortic lymph nodes. Whereas there are other studies which have shown long-term survivals in patients even with para-aortic lymph node metastasis. Based on this, the International Study Group on Pancreatic Surgery did not reach a consensus on routine sampling of para-aortic lymph nodes. So no strong recommendation was formulated for routine dissection of station 16 or its inclusion as a part of standard lymphadenectomy. There are only few studies worldwide and no published studies in India. The aim of this study is to assess the incidence, predictive factors, and postoperative outcomes of patients who underwent pancreaticoduodenectomy for non-pancreatic periampullary cancer with para-aortic lymph node metastasis. The primary objective is to assess the incidence of para-aortic lymph node metastasis in patients with non-pancreatic periampullary cancer who underwent pancreaticoduodenectomy. The secondary objectives are to evaluate the predictive factors of para-aortic lymph node metastasis and to evaluate the postoperative outcomes. This study is a single center, prospective and a retrospective cohort study set up in the Department of General Surgery, Surgical Gastroenterology and Surgical Oncology from a period of January 2020 to December 2023. After obtaining adequate clearance from the ethics committee, patients were included in this study based on the inclusion criteria that all patients with non-pancreatic periampullary cancer aged more than 18 years who underwent pancreatic or duodenectomy with para-aortic lymph node sampling between January 2020 and December 2023 were included in this study. The exclusion criteria of this study include pregnant and lactating women, patients with systemic metastasis, pancreatic or duodenectomy after neoadjuvant chemotherapy, intraoperative distant metastasis, and R2 resection. The sample size for this study was calculated based on a previous study by Hempel et al., in which the incidence of para-aortic lymph node metastasis was shown as 10%. Based on this, the sample size was calculated to be 100. Coming to the statistical analysis, all the continuous variables were compared using unpaired t-test, and the categorical variables were compared using Fisher's exact test or chi-square test. The effect estimates of factors associated with para-aortic lymph node metastasis were evaluated using univariate and multiple logistic regression. The overall survival curves were determined using the Kaplan-Meier method, and the differences between the survival curves were identified using long bank test. All the data was analyzed using SPSS version 19 software. Coming to the results, and this is the consort diagram summarizing my study. The total of 58 patients with non-pancreatic periampullary cancer underwent pancreatic or duodenectomy with para-aortic lymph node dissected and labeled for histopathological analysis. Out of the 58 patients who underwent PD, 9 patients had para-aortic lymph node metastasis, and the other rest 49 patients did not have any histologically proven para-aortic lymph node metastasis. The data from these patients were collected and analyzed. And this is table 1, which shows the distribution of baseline characteristics of the study population. The age, gender, body mass index, ASA class, and comorbidities were comparable among the study population and equally distributed, as none of the p-values were significant. However, it is interesting to know that more than 92% of the population were aged more than 40 years, with the predominant group being 40 to 60 years, which comprised of almost 45% of the patients. Table 2 shows a comparison of preoperative tumor marker levels among the study population. It can be seen that in patients with para-aortic lymph node metastasis, the preoperative CA99 levels was found to be 324 international units per ml, and the preoperative CA99 levels of patients without para-aortic lymph node was found to be 57 international units per ml. This difference was statistically significant. Hence, it can be concluded that patients with para-aortic lymph node metastasis were found to have higher preoperative CA99 levels. Table 3 shows the comparison of lymph node yield among the study population. It can be seen that although the mean number of lymph nodes and para-aortic lymph nodes are harvested are more in the para-aortic lymph node positive patients, but this difference was not found to be statistically significant, and the mean lymph node ratio was 0.6 in patients with para-aortic lymph node metastasis, and it was 0.45 in the patients without para-aortic lymph node metastasis. This difference was also proven to be statistically significant. Table 4 shows the comparison of histopathological characteristics of the tumor. Coming to the site of the origin of tumor, it can be seen that ampullary tumors were the most common type, comprising of almost 69% of the study population, followed by duodenal tumors, which accounted for 19% of the study population, and the least being biliary tumors, which accounted for just 12% of the study population. And lymphovascular invasion was seen in 89% of the patients with para-aortic lymph node metastasis, whereas it was just seen in 31% of the patients without para-aortic lymph node metastasis. This difference was again proven to be statistically significant. Other parameters like perineural invasion and margin status were comparable among the study population. Also, it can be seen that the staging of tumor in patients with para-aortic lymph node metastasis was shown to be significantly higher than the ones without para-aortic lymph node metastasis, with both T staging, N staging, and overall staging according to the AGCC 8 guidelines. AGCC 8 stagings were found to be significantly higher. Table 5 shows the comparison of post-operative outcomes among the study population. It can be seen that post-operative pancreatic fistula rates, post-pancreatic hemorrhage rates, Clavinito classification, and the mortality rates were comparable among the study population, and patients with para-aortic lymph node metastasis did not have a significantly higher morbidity and mortality. This is a Kaplan-Meier curve showing the overall survival of the study population with para-aortic lymph node metastasis and without para-aortic lymph node metastasis. It can be seen that the mean overall survival of the patients with para-aortic lymph node metastasis was just 12 months compared to 35 months in patients without para-aortic lymph node metastasis. This difference in survival was proven statistically significant. To conclude, the incidence of para-aortic lymph node metastasis in patients with non-pancreatic periampullary cancer is 15.5%. Para-aortic lymph node metastasis is associated with higher preoperative CA99 levels, lymphovascular invasion rates, lymph node ratio, staging of the tumor with poor overall survival rates. We recommend routine para-aortic lymph node sampling with frozen section in such patients with these above mentioned high risk factors. And in such patients, if frozen section comes out to be positive, we recommend para-aortic lymph node dissection. Thank you.
I just want to draw your attention to your title, incidence and predictive factors.
Yes.
What is the answer for that, incidence and predictive factors, from the data that you have collected?
Incidence of the para-aortic lymph node metastasis.
Is that what you're looking for, incidence of the nodal metastasis?
Incidence of para-aortic lymph node metastasis in non-pancreatic periampullary carcinoma patients, sir. Primary objective is
that
to
your
calculate the
primary
incidence.
objective? And what predictive factors are you looking for?
Predictive factors like preoperative CA tumor marker levels, sir, and tumor size, number of lymph nodes, and number of para-aortic lymph nodes harvested, number of lymph nodes harvested, perineural invasion rates, lymphovascular invasion rates.
And what is the range of follow-up you had?
Maximum being 4 years, sir. My study duration was both retrospective and prospective study. The retrospective went started from Jan 2020.
Okay.
So maximum patient was followed up for 4 years, whereas the last patient was followed for 3 months only, sir. December 2023.
What's your sample size, estimated sample size?
Estimated sample size was 100, sir, actually.
So show this slide. Your power is 80, right?
80% power.
With the 80 power and your sample size calculated is 100, but you reached the sample size of only 58.
Yes, sir. A lot of factors were involved, sir. A lot of surgeons were not aware.
No, I'm not going detail of that, right?
Okay.
So the sample size calculated is 100 scientifically, and you could reach not even a little more than half of the sample size. Is it reasonable to draw a conclusion on this? Because your power is already 80% only, right?
Yes.
If you're 95%, 100%, something like that, it is okay. But your power is already 80%, the lowest acceptable. And with that, is the sample size is 100. And you achieved only 58 samples. And drawing a conclusion based on this sample, I think it's not. And you're not mentioned that even in limitations. At least you could have added a slide saying that you could not achieve the sample size as a limitation. Because the conclusion cannot be accepted with this sample size.
Yes.
No, in a retrospective cohort, since that is not a routine, routine procedure of sampling the para-aortic nodes. So in the retrospective cohort, how did you get this para-aortic node sample? Which patients, why did they do, and what made them to do this para-aortic sampling?
Many of the retrospective samples were corrected based on suspicious nodal para-aortic lymph nodes on CT, sir, retrospectively. Plenty of studies were sampling lymph node station 16B1, which we were able to collect it prospectively. Whereas retrospectively, based on CT suspicion, multiple lymph node samples have already been sent. So I just had to find out those biopsy reports.
Yeah. So if they go to sample only CT suspicious nodes, that means they have left out the other cohort, which probably was not imaged and didn't show a significant node. So that is, and you have whether prospective, all patients you are sampling, right?
Prospective, all patients are
So
sampling.
that is again going to affect your result, right? That is one thing. And second thing, CA99 was very high, right?
Yes.
So what is the incidence of high CA99 in the periampullary tumors?
Since most of the patients had ampullary tumors, almost 70% of the patients had ampullary tumors.
In the literature, published literature, what is the range of this, what you call CA99? Is that elevated? We know in head of pancreas it's elevated. Periampullary also is it elevated?
Ampullary tumors, it is usually elevated, sir. Other distal duodenal carcinomas don't have such elevated CA99 levels when compared to ampullary tumors.
Your secondary objective was the mortality, no?
Yes, sir. Morbidity and mortality was one of the.
So what is the mortality results here?
Mortality, there is no significant increase in mortality in the patients with para-aortic lymph node metastasis, sir. The both 30-day and 90-day mortality were calculated.
Yes.
And it was not found to be significantly higher in the patients with para-aortic lymph node metastatic groups. Sir. Both are comparable.
Both are. And
even the morbidity rates are comparable between the both.
And that one Kaplan-Meier graph you have put, no?
Yes, sir.
So this is regarding survival.
Survival, sir. Survival analysis.
Survival also it is in the same way, or no? Survival is
significantly lower in the patients with para-aortic lymph node metastasis.
As compared to this. Okay, fine.
12 months in patients with para-aortic lymph node metastasis and just 35 months in patients without para-aortic lymph node metastasis. and this difference was proven to be statistically significant, sir.
Okay, fine.
Thank you.
Thank you.
Thank you, judges, for chairing the presentation evaluation.
Just take a minute. So we finished scoring. I have to say that all five of you presented almost equally well. All of you were confident and very lucid, and also importantly stuck to the time that was allotted to you. So our congratulations to all five of you. In fact, if you see the marks, there'll be minimal difference between the winners and those who are not going to win. So a big hand to all five guys who presented here.
Thank you all judges. Next session will be the post competition. I request all participants to be ready for it.